those of you who are familiar with the way the board operates knows that for the first half hour we exchange feedback from the various visits that we've done to the hospital earlier this morning. Many of you will know it's been a difficult 48 hours for the community and for the hospital, and inevitably, because of the tragedy that happened in Wimbledon yesterday and the patients that we have in the hospital, it has affected the whole hospital. Jacqueline and I actually visited the areas that have been most immediately impacted, and we will feedback at the end of the feedback when everyone else has done theirs. But I just wanted everyone to keep in mind that with the whole hospital effort dealing with the aftermath of yesterday's tragedy, and all of our staff have been affected in some way, and so that may well come through in the feedback. It may not, of course. It most certainly will when Jacqueline and I feedback at the very end. But I just wanted to set that context for the discussions that we have, and then we will move into formal board at 10:30. So I'm going to start with the first group on my list, which, according to my list, so these things are always slightly imperfect, was Andrew Asprey, Phil and Jenny. Was that right?
Correct.
Okay, who's feeding back?
I am.
Okay, Phil, over to you. We've got quite a lot to get through, so if we can be...
I'll be my normal brief self.
I can rely on you, I know.
I'm sure Jenny and Andrew may want to add. So maternity was our location, and we had a very calm, professional visit, I would say. It was really good to see the department, as I said, calm and professional. There were probably a few less patients in there than perhaps they normally have on a Friday morning, which maybe is, I'm sure it'll build up as the day goes on. And we went through the whole sort of process, how you get into the department, reception, triage, and all these bits, and all the way through. We met midwives, etc., who explained very clearly what they do, why they do it, and how they do it. So overall, I'd say it was calm. It was very tidy and clean. Yeah. I think I was very pleased to see corridors were not cluttered. I think it's the first time I've given that feedback, actually, and it was really good to see that it was well organised and people were, in their stations in the right places so they could, attend to the patients as necessary. Everybody we met was delightful, friendly, open, transparent. We talked for all sorts of things from, shift patterns to laughing gas. I can't remember what laughing gas is called. Entonox. So, which we break down the Entonox so that it isn't, adding to the environmental problems in the world. So there's a whole piece about that which is really interesting. And so, to be honest, Gillian, it was a very, I think, successful, professional, and I think there's very little one could say that was not, as we expected. It's very good. I don't know whether Jenny wants to add anything to that.
Did you, Jenny?
No.
Oh.
It's a great visit.
Lovely. Well, that's great to hear. Andrew, was there anything you wanted to say? Did you pick up some estates complaints while you were there?
I'm going to quit while I'm ahead because I think that will come later on.
Okay, right, thank you. So next on my list is James, Blythe, Kate and Martin. Did that group work? Yep. Yes, and who's reporting back?
We haven't agreed. I don't mind. Yeah.
Okay, Martin, thank you.
Yeah, I'll make a start anyway. So again, very similar, very positive. We went to two surgical step-down wards, and then we also visited, interestingly, a completely empty ward, which is major trauma, which had just been refurbished. And part of the point of that was it's just about to open. And I'll start with that one. It's absolutely fabulous what had been done. The design of it, it all felt incredibly new, and of course the equipment was new. The other wards we went to, calm, professional, very busy. From a lay perspective, I really noticed the difference as to how close staff have to work to each other, just the way the workstations are, and the number of staff in a small area. There were a couple of things that were particularly interesting. I thought. I know that James got a lot out of it in terms of understanding about what the issues were with Cerner and the implementation of employee records. And on that, it really stood out. You can have all the wonderful system, but you're still very dependent, of course, on the infrastructure and the Wi-Fi, because clearly, you know, it gets pushed around. And the IT was interesting as well, in that even with the new ones, I couldn't get my head around why you had these massive, great trolleys with this huge equipment on it, when most of the world these days just walks around with a little tablet. And the staff kind of thought it was the same, so that was a bit puzzling. And a very good initiative, which I don't pretend to entirely understand, but something about trying to get people through beds quicker, and because they recover more quickly, with traumatic brain injuries, a whole new team, as I understand it, with beds allocated for that, on the premise that if you have more intensive care, including physiotherapy, early on, your recovery is better and quicker, which ultimately obviously affects bed occupancy. But I was conscious I was with two experts, so I'll defer to them for anything else.
Kate, was there anything you wanted to add?
Just very briefly, so it was Gunning and Keat that we visited, so thank you, Martin. And I think probably just a couple of things of note. One, Keat ward was the first ward to become COVID and the last to come out of COVID, and it has and then it's now, because Holsworth ward, which is going to be our major trauma ward, both Keat and Gunning have had to slightly change the type of work that they're delivering there, as Martin has said. So, and there's a plan when Holsworth reopens, that Keat will change again and have some traumatic brain injury activity going through there. Both wards had very stable staff groups, quite well staffed. A couple of things that they picked up. One, they were just saying the computers on wheels, that some of the trolleys that were on didn't rise and fall anymore, but it seemed that they had to replace everything, including the computer, when that happened, when the computer was still functional. And as Martin said, I think particularly on Gunning ward, it was quite tight for space. There were a lot of computers on wheels. It's a very, very busy trauma ward, trauma stroke, emergency orthopaedic ward. So I think felt like there was a lot of equipment on the corridor, a lot of it computers on wheels. So if they could be neater and tidier, as Martin describes, I think that would make a real difference to the clinical team. But generally positive, not really saying they needed anything that hadn't got. So yeah, it was a positive visit. And we also looked at Holsworth. I suppose the great thing about seeing Holsworth, and as you know, it's not quite open yet, got a few issues with it, but it is absolutely beautiful, and you can see what you can do with quite old estate in terms of it feels and looks very different to Gunning and Keat, and everyone's very excited about it. So we just need to get it open.
Well, I think you took the words right out of my mouth, Kate. I was going to say, we just need to get it open. I know James Blythe's arrived, but I'm not going to give him the opportunity to add to the description, because we've got a lot to go through. So apologies in advance, James. So the next on my list is Arlene, Thurza and Anne, who went to outpatients in Freddie Hewitt, according to my list.
Yes, which turned into Derek and Thurza, and we were shown round by Steph, Doreen and Millie, but Derek was going to say some words first.
That was quite a little party, wasn't it?
It was a party, yes. It was a very good party. So we went to Freddie Hewitt first. We spent Freddie Hewitt's paediatrics, general medical paediatrics, plus a considerable emphasis on looking after children with mental health problems, to the extent that they have a specialist bay where they work very hard to make it safe for children with major mental health issues, and they've got another child who's, or a young person who's in that category, who's in their own bay with, I think, 2 mental health nurses looking after them one-on-one. So there's clearly a big emphasis on looking after children with mental health issues on Freddie Hewitt, as well as looking after children with medical problems which aren't specifically related to mental health. It was clearly a very challenging environment, and I think there have been recruitment issues because of that. The nurse in charge we spoke to, she'd been there 9 years, and she obviously felt a great deal of loyalty to the team. She felt that staffing was a problem. I think they've got 13 vacancies, and she said they're on a shift with 6 people, 6 trained staff supposed to be on. They've only got 5, and the other day they only did 4. She's having to do an extra shift tomorrow night because they don't have staffing. So, that's part of the territory, I know, but clearly something that affects them. They are very well supported. I got the impression from the nurse I spoke to that she felt a bit over-supported, and well, not in the sense that people are always coming to say, "How are you coping? How are you coping?" And she's been doing this for 9 years, and she probably knows how to cope now. But I think she appreciated the fact that people kept asking how she was coping. The environment, it is a 70s building. It's very tight. It did feel a bit cluttered, but I think that was because of the building rather than because of. Maybe there are ways of storing stuff outside of corridors, but they'd worked very hard to make it a pleasant environment. They'd created a quiet room for children who were stressed. So I think that's what I'd say about Freddie Hewitt. I was going to move on to outpatients. Do you want to add anything else about Freddie Hewitt?
They played their part in what had gone on yesterday, actually, and certainly Steph was very keen to thank all the people who changed, because what they tried to do was pull children in from ED to create space in ED, and we did check out that they had been properly supported. Obviously nobody wants to go home with all that trauma still there, so that was it was good to hear actually that it was a whole hospital approach. Two other things that struck me. One was the range of children. So they had little Cassie in there, who's 7 months old, refusing to have his nap. And then they can take 17-year-olds. And it's a very, very broad range. And, you've got in some of the bays, you've got a cot and you've got beds. And I just wonder if that's the best model, given what's going on. The other thing, because it's really interesting for me, talking about patients with mental health issues and how we work together with the trust. But they were talking to us about the role of social media now in children creating sort of plans together and how we kind of get into that world, which I thought was worth thinking about.
James Blythe and I had a discussion on that very point yesterday, did we not, James? But you went to outpatients
briefly,
as well?
Yes, we went to outpatients as well, went to the chest clinic area. It's a very tight area and there's a lack of storage there, so there's sleep apnea machines piled up in the waiting room. I spoke to one patient who'd got a problem with her sleep apnea machine. This is a random sample of 1 of 2. The other patient I spoke to had a very good experience. This lady had phoned on Monday with a problem, didn't get a reply. Phoned on Wednesday, didn't get a reply, so ended up just deciding to come in. So she walked in and said, "I've got a problem with my sleep apnea machine. It's not been working since Sunday." And so there's a service issue there. That's not the quality of service we'd hope to reach. It's a one-off. And one of the other things that came up in our discussion, fracture clinic, much more spacious. There's some login machines that we're getting rid of because the IT doesn't work. So, but that seemed to be something that was being dealt with. And the person I spoke to there had a very good experience. And the other thing that came up there was this tension, perhaps, between the outpatient services that are run by corporate outpatients and those that are run by specialist units, and whether that means you get a different quality of service or a different type of service. And we could see there are wins on doing both, but we seem to have a hybrid system at the moment. And whether that's the best system or not, I think, came up in conversation. Would that be fair? And do you want to add to that? Sorry.
The only other thing I was going to say, which was also really around governance, was that they'd had particular issues with sort of managing the sluice rooms, or the dirty rooms and the clean rooms. And they'd been in quite a difficult state for some time. They're still not great, and there seems to be more work to do. But I think the thing that struck me was people had tried many times to raise this and get help, and hadn't got help. And actually the thing that brought it to light was the ward or the service accreditation scheme. But it made me wonder if there's a gap in our governance somewhere, because people give up when they've tried to raise something, and then they couldn't. And it was only when it came out in the accreditation that people went, "Oh my goodness," and something was started to be done about it.
So, Anne, you're so right. And I visited that area with one of Arlene's senior, Janice. And spoke at length to one of the members of staff who made that point. Staff just give up if they're not listened to. And day ticksers keep being, anyway. I certainly wrote some of my, howler emails on the back of that. But Janice, I know, had some ideas, but I've certainly got on my to-do list to check that that's all happening. Arlene, did you want to give us a positive report on this?
Yeah, I do actually, because a couple of weeks ago it was even worse. It's not great, so I did go down this morning because it is one of the areas that I check in all the time on since I discovered it. The good news is that there was some staff facilities, so there's a changing room where staff in the toilet, but it was in a really, really bad state. The walls were cracked and I raised it with estates, and on that weekend it was done. And I saw it this morning, and it looks beautiful. So that's a positive bit. One other thing was that the day that I visited was really very hot, and they again asked for a fridge over and over again, and nothing had happened. But we managed to get them a fridge on that same day. It's still not great because all of these machines are piled up, and that clinic was full this morning, and we have all these machines piled behind the patients waiting in the waiting room. So there's lots to do, but we're making an inroads. From an infection control perspective, though, we need to do a lot better, much more quickly than we are doing now.
Thank you, Arlene. I'm really grateful for all the efforts that corporate nursing have put into this, but I think it's probably a broader issue, Jacqueline, for the whole executive team about the fact, as Anne said, the staff there they've just kind of given up complaining because they didn't think they were getting anywhere, and that's just not where we need to be.
Do you want me to say something very briefly about that?
I think it would be helpful.
So I suppose I had my own little experience in one of our wards, and it really made me realise that when things aren't working, it actually makes the working life of our staff really difficult. And whether it be IT, and it's usually either IT or estates, for whatever reasons, that how do we really, and we talked about this, or I talked about it to the team on Tuesday, about how do we really get a lot better at not only just picking up the day texts, but also, because I think that's the bit we maybe need to look a bit closer at, but also I know Andrew's now put something in where actually they're looking through every bit of every day. Every week somebody senior goes through what's on the list to do, so that we don't have something that might not be a category, whatever you call them, these doing today, but then because of that never gets done. Yeah. So I think there are things here about how do we really make ourselves more responsive, because you know what? When the sink in the shower got fixed in my room, it wasn't because it was it was because it was me, because I said, please can this get fixed. They were thrilled that it got done. And I've never seen so much joy in somebody's face, so in the staff's face, it's true. So it is something I think we really need to get better at, about how do our supporting teams, and I know it's difficult and it's not always as straightforward as I'd like to think, but that we do actually mend things for people and get them working sooner rather than later, because otherwise people they stop seeing it and they stop reporting it, so they don't think there's a point. Yeah.
Thank you. We could spend longer, I'm sure, but we need to move on because time is tight. Andrew Grimshaw and Stephen Collier, according to my list, is that right?
That's absolutely correct. So if I go first and report on the first half, and Andrew on the second half, Gillian, both of us will be brief. So Andrew, Marlene and I visited the Ruth Miles ward, second floor St James, and Andrew and Marlene then went on to the haematological day unit on the same floor. The patient caseload in Ruth Myers is haematological inpatient, so red cell bias, solid tumours, lymphoma, myeloma, and some hospital and actually regional specialties of stem cell and bone marrow transplants. So quite an immunocompromised group of patients. Our overriding impression was of a busy, happy unit which had just achieved its silver accreditation, and you could see why. It was well organised, very tightly managed, but quite friendly in the way it operated. Dedicated staff. The great thing is staff who stay. So long-serving staff, the ward sister's been there 8 years, has moved through the bands and is now a senior band 6, and she's been homegrown and home developed a loyal bank and very low agency usage, although there was one agency staff member there today, and you could see she was welcome, but they didn't think that was quite right. They're very proud of what they do, and they do it well. And importantly, they're really looking forward to the new CAR-T programme that we're about to launch. This is a huge investment for the Trust, and it's very clear. It's been very well thought through. They understand what they're about and the significance of what they are going to be taking on, and we've invested appropriately for it. I think that came through very well. We had a number of discussions about tech, premises, and the overall sense was they're doing the best they can with some challenge, but it's managed well and effectively. We had a short discussion about length of stay, particularly for the stem cell and bone marrow transplant patients, and there was some sense from the nursing staff that the consultants are quite protective of beds and patients, and that retention on the ward isn't always clinically necessary, though probably desirable, given the immunocompromised nature of the patients. But there's probably a case for a clinical review of whether that length of stay is entirely appropriate. But overall, we left impressed at the staff, motivation, experience, team working, and the way they were delivering service to patients in an empathetic and I think incredibly supportive and appropriately robust manner, bringing patients along. Andrew?
Thank you.
And I'll mention one thing. I don't mean to dob you in the basis that after you left. So
what's really going on?
Yeah, no, which was said about Ruth Miles. There was actually a really positive attitude, as Stephen said, but about the challenge of being aware of the pressures in the hospital when sometimes they can't easily take patients in, given the nature of the caseload that they do. But they were saying they were working with the consultants and IPC in terms of how they could flex that. So they really wanted to engage in that, I felt. And that was a really positive thing, I felt, in the sense of being conscious of the wider pressures as well as their own and wanting to support their colleagues. So, I went on to I'll keep this very brief, in terms of the haematology day unit, and then I went to McKinty ward as well. Very positive. Haematology day unit double gold, and they were very pleased about that. Really positive staff. They were well staffed. There was some, welcoming a training program that's recently been started so they can start growing their own staff, which they saw as really good. Had been a challenge for them in terms of recruitment. Key issue, and I heard this having been there before, in the sense of is the space. It's less than ideal, in terms of the number of sort of couches and seats they have for treating patients, and the fact there's no isolation space. So if they have any issues with patients, and also any sort of inpatient capacity. So if there are challenges with patients, finding them a bed can mean there are staff staying on the unit till 9, 10 o'clock at night, looking after patients, waiting to find them a bed. So there's a real pressure in that. And if you go to the unit, it's well maintained, it's clean, it looks like it's worked, but it is small. You can see that. I spoke to a volunteer there, really positive. She's been working 22 years. She mentioned the IT. Not for the whole 22 years, I'll add, but she said it was slow recently, and that was also fed back by one of the receptionists. And also spoke to a patient who was absolutely completely complimentary about everybody, and he said he'd had brilliant care, and he just couldn't, he had nothing of fault to say at all, and he was really, really positive. McKinty was described as a warm bath compared to other units in the hospital by one of the senior sisters, who said, when you come and visit, it's been recently done up and it's a lovely environment and it feels nice and it works and it feels comforting in terms of where it goes. But again, there were pressures on space in terms of just the numbers of rooms and how you can deal with patients. And again, high numbers of patients coming through and they're sicker. And the lack of side rooms in the hospital in general, meaning that actually if there are patients coming into ED that need that pressure, there's sometimes pressure to push them into places like McKinsey where we have side rooms. and that's then a challenge in that area. So it's that general need for side rooms, particularly at the front door, to allow us to manage, particularly in a post-COVID world. But very positive overall.
Thank you, Andrew. Stephen, I'm being terribly indulgent,
Yeah, you
but
are.
we're
And
going to overrun.
It'll be a tweet. Just the thoughtfulness of having a teen/young adult room on a long stay unit like that, I think that stands out as something that reflects the staff's consideration for a particular cohort of patients. It was obviously well used.
Yeah, really well made, Stephen. I think so often our staff give up their own facilities in order to do the very best for their patients. In the end, they can't keep doing that because they've got nowhere to get changed and leave their lockers and all the rest of it. I'm sure that Derek was very pleased to hear about McKinty since it's his ward. And I'll talk to you later about whether a warm bath is the right expression for it, Derek. Next on my list is Paul and Chris, and if my list is right, you went to Theatres and Recovery. Is that right, Chris?
Your list is very accurate.
Excellent.
So thank you. So I'll try and be brief and ask Paul if he wants to add anything. So we had a very fruitful visit. We were greeted very pleasantly by John, the head of nursing there, and by Caroline Johnson, one of the senior anaesthetists, who supported the visit very well, I thought. The general feeling walking into the area was it was a friendly atmosphere. People were walking around. There's a big long corridor outside the theatres, and people sort of nodded to each other in recognition, which I thought was good. The corridors around and the anaesthetic rooms, we didn't actually go into an operating theatre itself, were very clean and tidy, if you can be tidy when every space is taken up with a bit of machinery or a cupboard for this or a cupboard for that. But once you look past that, you could see that it was tidy and organised. And that clutter, if I might call it that, is an issue for them as they try and move around, and particularly if there's any crises that occur. And the thought of perhaps if there was a fire there when everyone had to rush out, that could be a challenge and a risk. And that is, I understand, on their risk register there. There's nothing immediate that one can do about that, but I guess it sits there as future planning for St George's. The staff were appropriately dressed for the areas that we're in. We didn't, as I say, go into the theatres, so I couldn't check that they were wearing gowns, but I presume they did. There's a lot of good signage around, I noticed, particularly in the anaesthetic rooms, about the pre-op checks that need to be done. And though it was interesting, we talked through one of the pre-op checks, it was, at the bottom line, there's a bit that relies on human information, which is asking the patient where their operation is going to be, which, I mean, the patient, of course, should know, but however hard you try with IT and all that sort of stuff, at the end of the day, your final check can be asking a person what they think is going to happen to them. Talking about the staff, I mean, there are nearly 400 people, non-doctors, who work in theatres, apparently, which is a large number of people. We met about 5, as well as Caroline and John, we met about 5 other members of staff, and they all said what they thought best about working around the place was the staff there, and what a good feeling there was between all the staff and how they'd worked together. I did note that they were, once we'd finished talking with John, he was off to what they call a gas and coffee session, which is a debrief, which I think was particularly pertinent today in view of the fact that the theatres had to manage some of the poor people involved in the accident yesterday. So that was very positive feedback. The key thing, other than space, that I think I wanted to mention was what they all said is flow through theatres. And when you talk to different people at with different roles, you could see the complexity of flow from the arrival of the patient, though they felt planned care flow was easier than emergency flow. But people delays in getting patients up from A&E because there isn't a member of staff to take them, all the way through to delays moving patients out of theatre into recovery because recovery can't move people onto the wards or to ITU. I did talk to one of the nurses, and I said, asked them if they'd worked at other hospitals, and I said, did they have any answers to any of these issues at the other hospital? And they said no. But we did think that maybe the head of nursing could do, maybe visit some other hospitals and see if they've got any bright ideas for helping this flow issue. But the consensus was that it's not unique to St George's. So that was really the main thing. There was an issue around, so talking with Caroline, she felt that they had really good relationship with their trainees. There was one, their juniors, there was one issue there about the junior anaesthetists having to stay in the emergency department with patients who need transfer to ITU, but there isn't an ITU bed, so they can have to stay 6 or 7 hours down in emergency in a role which they have to be there for, but is not, is very tedious in some ways, and also not an efficient use of their time, and can break into their training abilities. I wrote lots of...
I hope that's it, Chris.
I think that's it. Yes, I can take a hint, Gillian.
We're tight on time, so thank you. Paul, I hope not much.
No, just very quickly, just say it was good to hear the staff were really positive about the training they received, the work environment they were really pleased with. There was just one issue that they raised was around taxis and late working.
And we know about that issue, and I hope it's being rigorously followed through, is it? Because
you can understand how annoying it must be. You've worked a long shift and you have to wait.
Beyond annoying, I also, of course, understand some of the practical difficulties, but we need to find a way through. Yeah. Thank you. Sorry, this is overrunning, and so we're going to start feedback quarter of an hour early next time because it's a bigger board now, and clearly it's a struggle for people to say everything they want to say in the time available. So the penultimate people on my list are Richard and Andrew Murray, and they went to cardiac and neuro theatre, so there's a theatre theme going on. So, Andrew, could you convey to us the essentials of what you saw and heard?
I will try and do that as concisely as possible. So similar issues to general theatres, I would say. We visited neurosurgery and cardiac theatres. The positives, I would say, what came across quite strongly was a positive culture within the clinical teams. They were calm, well-run, clean places to work. It was well-ordered. Neurosurgery were very proud of their Gold Award. They had the equipment they needed to do the job. The things that perhaps that we noted were neither theatre area had a receptionist, so clinical staff were having to answer the doors. Understand from what they said that was down to just not having the funding for receptionist roles. In neurosurgery particularly, there was a huge amount of equipment stored in the corridors. They need loads of kit there and they don't have the space to store it, and they have a lot of loan kit as well. But it was stored as safely and as well as it could be. Nursing staff recruitment and retention was a key issue for both areas, I guess particularly because you need specialist nursing, and that was a difficulty. And then the other big theme that came up was flow. I think particularly for complex procedures, knowing that you've got ICU space was an issue. Now, I would say that the general feeling was that had improved because there had been initiatives to look at that recently, so it definitely improved, but still remains an issue. There are a couple of things about to come online that will help. So there's an intermediate cardiac beds that are about to be opened, which will make a difference to that, as well as apparently plans to create intermediate neuro beds on Brodie ward, which will allow those patients who don't need full ICU to go to those, which will help flow. There was an issue that you've got staff there ready to go at 8 o'clock, but a number of these complex operations don't start until 10 because you have the ICU huddle at 9, and then you have a delay. So although that's improved, it felt there was probably some efficiencies there, but I understand that's a complex problem. But in summary, I think one of the clinicians we spoke to summed it up really nicely, which was, on balance, the positives outweigh the negatives, and they wanted to keep working there.
That's a very nice note to finish it on, Andrew. Thank you. The last group, apart from Jacqueline and I, but we will be incredibly brief, was James, Marsh, and Yin. And
I'm going to start.
oh, right. But you're both very conscious of time, aren't you?
So I'll just go back through my notes. So we visited the senior health wards with Leanne, who's recently returned from maternity leave. We were reminded that senior health is a term that was co-designed with patients, and encouraged to use that term rather than care of the elderly or geriatric. So that was a good lesson for us. So lots of positives. Clearly, strong multidisciplinary team, cohesive, lots of pride in the way that they were working. It's part of the older part of the hospital, but they are Dolby and Heberden are wards that have been renovated in the last 4 or 5 years, and it does show that where focus can be put into thinking about the environment and the purpose of those wards, you can make a really pleasant environment. It was generally uncluttered, and you could see that the ward environment was appropriate for frail elderly patients. There was definitely an air of calmness and care. And I was checking with a doctor who was using the IT, and he was saying the IT system was not an issue and the Wi-Fi was working well for him. Some of the challenges, flow seems to have been an issue that we're talking about today. So in non-elective, it's certainly a frustration for care of the elderly, both at the front end and the back end. So the teams on Dolby Ward reflected that almost half of their patients had no ongoing medical need to be in a hospital and were frustrated about delays in discharge. And they did also comment that perhaps as an organisation we could do better in terms of communicating what proactive steps we were taking to support the general complex system of flow. And then at the front end, they were also frustrated about the need to board patients on the ward to support flow from ED to relieve a lot of the intolerable pressures that the emergency department face. I think on balance, they recognised it was more positive than negative, but they didn't underestimate some of the challenges that they were facing. And then one final thing to note, which I've escalated already to Andrew, the team clearly took a pride in the environment, and they were trying to improve and rectify an estate challenge with a door that abutted between Heberden Ward and Trevor Howell, where there are different types of vulnerable patients that had been escalated for being able to be locked to stop wandering patients going between the wards, and it was taking a long time to fix. I don't know if Ian wanted to say anything else.
I was just going to say, given your very comprehensive update and in view of the lack of time, I have nothing further to add.
Go on, you're allowed a couple of sentences. Are you sure?
Oh, okay then. No, just say that it was really lovely to meet the members of staff. There was a very engaging ward clerk there, and she had fantastic folders which were all lined up, and I thought that was really nice. It was a very good atmosphere too. Thank you.
Lovely, thank you, Yin. That takes us finally to Jacqueline and myself. We went to paediatric intensive care, Nichols, ED, UTC, and the general intensive care, and our purpose was to thank the staff for everything they had done yesterday. Cue you.
Oh, thank you. Is that what you're going to say? I think the conversations we had with them were personal and thoughtful, and we thank them on behalf of the board about how well they had led, and we as an organisation had had responded to yesterday. I think the only thing I want to say about yesterday was that we did respond incredibly well in what was a very difficult situation. And I think the bit that makes it more difficult, not only because children were involved, along with some of their parents, but also that the area it was is very personal to George's. It's part of our local community. And when you walk around the hospital, you recognise, and I and Kate have had emails all overnight from staff and from outside of the hospital as well, who everyone has been touched by someone they know who either goes there or knows someone who goes there. And I think there's one line that kept getting repeated to me in the emails I've received, which was, I went home last night and I hugged my children closer. And I think that says it all, really.
It does indeed. Thank you, Jacqueline. And thank you, everybody. I am definitely going to, Phil may say something when he leads the reflections, but this is a part of the board meeting, informal, before formal board, but it's very important to all of us, I think. And I don't like it being squeezed, and I'm conscious that I've had to hurry people along, and we don't always, we're not always able to follow up some things that, whilst we don't want massive conversations at this stage about them, it would be more useful if we could. So I think we will extend the time for this session from the next board meeting, recognising that it is actually 2 board meetings, so we've squeezed an awful lot of activity into half an hour, and probably too much. But thank you, everybody. I've certainly written down a number of things that I will be following up. Some I already knew about, some that were new. And I'm sure, and I sincerely hope that the relevant executives have done the same thing. A warm welcome to everybody, including our governors and members of the public. I have a number of apologies from Tim Wright, from Aruna Mehta, from Stephen Jones. Otherwise, I think we're all here. And apologies for those of you, particularly Jenny and Martin, who seem as though they're kind of squeezed at the end. We need to organise this a little better, I think. Certainly somebody could have sat up here next to Jacqueline. There's a space that wouldn't have involved being squeezed at the end of a table. Are there any new declarations of interest? No? Could we agree the minutes of the last meeting, which was our first meetings in common a couple of months ago? Everyone happy? Thank you. Could we turn to the action log? There are a number of, there's only 4 items on it, but there's some updates that we need. And the first one is about abuse, abuse that our staff experienced from patients. It's been hanging around on the action log for some time now. I wonder, Richard, if you can update us as to the current situation?
Thanks, Gillian. And we might want to leave it, I don't know if we want to leave it on the action log for one more time, but essentially we've had a number of conversations with a number of departments, and the message that's come through to us very clearly is that if we want to support our staff better, it would be good to get into a rhythm of you said we did communications about what we can do to improve people's experience when they do face violence and aggression. And there are lots of different themes here. There are some practical actions that have been suggested to us for the emergency department here at St George's, but also quite a lot of things which we're working through with the different ways in which the Metropolitan Police is going to be working with emergency departments in the future. And I think if this sounds all right, Chair, we could draw all that together for some final summary at the next board meeting, if that sounds okay.
I think that would be very helpful, Richard, because I'm just conscious that there are lots of things happening. It's an ongoing issue, but it just keeps popping up on our action log.
Chairman, I'm just looking at Paul, because I think this is one of our big 5. Yeah. So we can bring something back, because there's loads of stuff going on. So,
I know there's loads of stuff going on, but nobody lands it at board, and until it's landed at board, I think you all know it'll keep appearing on this action log.
So I would suggest that Paul brings something back formally via the People Committee, because it sits mainly with Paul in terms of doing something, though it links in with Andrew. So we will collectively bring something back, Julian.
Fine.
We're happy to do that.
Happy to take that as an
action. Thank you very much. And I don't mind, Paul, it doesn't have to be for the next meeting, but I'd rather have a comprehensive report that enables us to properly cross this off the list. Recognising that it's an ongoing issue. I'm not suggesting that we're going to end the problems. That's helpful, thank you. And the next item is on maternity services. And This is about just how the 2 investigations are going, Arlene?
Thank you, Gillian. So on the Embrace review, that has started, and the team it's 78 cases that they have to review, and they've asked for 20 every 2 weeks. So that's the kind of timeline that we're working to, with a final report ready late September, early October. And the culture review is wrapped into the general, not the general, but the focused review on governance, where we will start with maternity as a whole.
Can I just clarify that? The culture review has been picked up as part of the governance review, did you say?
Well, yes, some elements of it is being picked up as part of the governance review.
Right. But we're still doing a separate cultural review, are we?
Yes.
Yes, okay. So there's the Embrace, there's the cultural review, and there's the governance review. Yeah, okay. Everyone clear? Andrew doesn't look entirely clear.
Just, so what's the time frame for the culture review and exactly where is that at?
So
I'm less than clear.
No. So the culture review, the terms of reference have been sent out, and we are having to do the procurement process for that now.
Okay. I would prefer, knowing that Quality Committee is actually monitoring this really carefully, and we'd get regular reports to board anyway. Is it okay if we remit this to Quality Committee, Andrew? Is that all right? Otherwise, we're having the discussion twice. And whilst I know the whole board is concerned about that, because we get the separate maternity report, I think we could probably leave the detail to Quality Committee. Are people happy? Then we can close that one down from the point of view of this particular aspect on the action law. And then the next item was a very specific one about information on maternity services. Arlene.
Yes, and it was adding the number of births a year, and I'm not sure that we managed to do that this time, but we will. Yeah, so I'm happy to keep that there, and we will ensure it's done.
Okay, lovely. Thank you. Hopefully we can remove that next time round. And the final one is proposed for closure, and that was, I'm not going to read it all out, it was a surgical site infection issue. Yeah? People happy to close that one? Lovely. Thank you very much indeed. So that takes us to Jacqueline's report. Welcome back formally, Jacqueline. We're all delighted to have you here. Over to you.
Thank you very much, Chairman. So I suppose it's been a bit of a mixed week, really. On Wednesday, we celebrated the NHS's 75th birthday. And I think spirits in all of our bits of our organisation were high. And interestingly, we had the TV, you and I had a TV crew trailing around after us. And,
an interesting experience.
Yeah, and they asked me when they interviewed me at the end of it that they said they were quite surprised that, given everything that was going on, strike action, etc., they thought that staff might be quite downhearted and not really engaging in this. And they were really surprised at how positive staff were, the welcome that everyone got, and how people were taking it very seriously and actually celebrating the NHS. And we certainly had a good time, actually, didn't we? And I think the staff did as well. Lots of stuff going on, including planting of trees over at Epsom and
a
lots
picture
of cakes.
James grimacing.
Yes, that was...
Sorry, James.
We had a caption competition for that. Also that afternoon, I was very pleased to be invited to go to the Parliamentary Awards. And this is where local MPs nominate particularly groups or individuals in their local hospitals to receive an award presented by the NHS senior national team. And we had two people who were nominated who also got shortlisted. So one person got shortlisted from each region. And we had our emergency department homeless team at St George's, and also we had one of our breast nurses, Charmaine Case. And Charmaine actually won the Lifetime Achievement Award, which was absolutely amazing. And she's amazing, actually. And when I went asking about her a little bit before I went, the amount of positiveness and how much care she gives to other nurses was just amazing. She also is the president of the Nurses Association of Jamaica. So she's a well-known, well-loved individual, and it was well-deserved. I'm not sure I'm going to mention anything else because everyone's read it, other than just to say congratulations to our Anna Mack, who we have formally appointed to the role of Group Chief Communications Officer. Otherwise, I'll go on for ages to me. I know that's not allowed.
Well, it's better if people can ask questions, but I think we would all want to endorse the congratulations to Charmaine and to Anna. So, questions to Jacqueline. Peter, I saw you first.
Yeah, thanks, Janine, and a really big welcome back, Jacqueline. You mentioned in your report about the long-term workforce plan that has been announced. Really welcome further investment in places for the future, but with the best will in the world, it's going to take time for all of that to come out at the other end and to be able to address some of the current issues. So I just wonder what your reflections are about how we manage in the meantime other steps, whether it be retention or other means that will help to address some of those current workforce issues. Thank you.
I think the biggest thing is the retention issue, and there are 25 trusts apparently around the country who are doing individual work, and we're trying to work out whether we're one of them, because we're doing a piece of work on some retention stuff as well, where some of the data coming out is actually showing that they are retaining staff better. So hopefully all those bits of threads that 25 of us are doing will get pulled together and actually come out with, you know, how do we really retain our staff? And we know some of it, don't we? We know that often staff join organisations and leave managers. So quite a bit of this will be around our local leadership across all our domains. But there's other things I think they're looking at as well. I think that's the best thing that we can do because we have huge turnover, which has only got worse since COVID. And we, as you know, through People Committee, we keep a really close eye on it. But the other bit as well is we need to get engaged with how actually we do develop apprenticeships, how we do work with local universities, how we do, there's a whole load of work for us to start to do to enable that to be a reality as well.
Phil.
Thank you. You also mentioned in the report the recently launched group strategy, and which I think is a very important piece of work. And so I'll just say a little bit, if you wouldn't mind, Jacqueline, about how that's being communicated out to the rest of the team, really.
The rest of the organisation?
Yes, yes.
Well, to be honest, given how it sort of got launched when I wasn't here, I might lob that to my deputy James, mainly because I haven't got up to speed with some of it, although or with everything, and this is probably one of the areas where we've started to talk about how do we make some of this a reality. But James?
The strategy update is an agenda item later on, so perhaps shall I cover that later on in the agenda?
Is that okay, Phil? Do you mind? Yeah. Okay, it seems a neat way of doing it. Any other points people wanted to raise on Jacqueline's report? Anne? I thought... I don't want to encourage you if you didn't want to. It's just
No,
it was as though your hand was heading towards your microphone.
I was going to get a glass of water. I suppose I was reflecting on, it seems to me that the Kids Deserve George's campaign seems to be going quite well. And I wondered if there was anything you were able to say at this point about where we are.
I think no more than I'd said in the report, but we might have a bit better chat about that in part two, if that's acceptable.
It's entirely acceptable. I'm sure I'm going to agree with that. Right, I can't see any other hands. I can't see any other hands heading towards their microphones. So if we could agree to note that report, and then it takes us on to item 2. And the first item is the establishment of of a new infrastructure committee, which I think we all know and understand, and I think support in an effort to get better assurance on those areas by providing more time for their discussion. So this is Stephen's report, so I'm not sure. Were you going to say something, Andrew? That's really helpful. Thank you.
Thank you. Thank you. You've possibly said everything that I was going to say already, but I think it just recognises that we've had a estates assurance group at Epsom, which we'll come on to later in terms of where we've got to there, and some recommendations that we have for moving that forward that have been picked up in these terms of reference. I'm working away on a group estate strategy. We're working on a group sustainability plan, and I think this forum gives us the time and the breadth to cover a whole range of issues. I can't take any credit for the terms of reference, that's all Stephen's work, but there's a huge amount in there. So this would cover the assurance on E&F that you would expect. It will cover IT, but we'll also then have time to talk about the green plan and sustainability, as well as health and safety as well. So I'm very, very keen to get this up and running.
Thank you very much indeed, Andrew. And it is going to be a bi-monthly committee, isn't it? And Anne's kindly agreed to chair it. We have penciled people's names in, not all of whom I've been able to have a conversation with, because this all kind of came together rather late in the day. So if you see your name there and say, well, it would have been nice if someone had asked me, my apologies in advance. I will have the conversation with you. So we're asked, I can't see any other hands. Oh, sorry, Peter. Oh, and Chris. So.
Yeah, sorry, just to welcome, support the recommendations, but it's just whether or not, if it's not time limited, and I'm assuming it's not at this stage, then to build in a review point after, say, 12 months, just to, and maybe that will happen anyway, but it's just to, you know, it's always good practice, I think, to see whether it's actually delivering on its terms of reference and achieving what it wanted to achieve. Thank you.
I'm sure that's right, Peter. Chris?
Thank you. I'm just mindful of my visit to theatres and the way that the space has been overused up. Now, a few years ago, the theatres didn't have a half of the equipment in them that they used to have. So I guess my question is there an element of horizon scanning as to how the needs for space and infrastructure looking forward could affect what we need to do? Things that aren't predicted now, but could be in a few years' time. Thank you.
Thank you, Chris. So, James, you'll pick up building your future hospital, presumably?
It wasn't that, actually, that I was going to talk about. I mean,
right.
I think that I wanted to come in and just support having this, and the reason I want to support having it is that I think that there is huge scope for us to be more proactive at site level as well, in terms of how we address infrastructure issues and how we do exactly what Chris talks about, which is, instead of sort of reacting to our infrastructure issues, that we do actually make sure that we've got those systems to plan ahead, that we're making the links between estates and infection prevention control, between IT and clinical operations, thinking about how we build sustainability into our approaches towards staff travel. So I think that this is exactly where I think this committee will help us to focus as a group. And then also to help make sure that the board is able then to put the right challenges back down into the sites, to make sure that in the way that we run the sites, we've got a really strategic and proactive focus on infrastructure issues, and that we're really building them into how we plan for the future. So I think that's exactly where I think it will drive us to, and I think it's exactly where it should, and I'm very pleased that we're doing it.
Thank you, James. Anyone else wanted to say anything? Do you want a final word, Andrew?
I think just if I can just pick up on the point of future looking, part of the 6 facet surveys that are referenced in the terms of reference, which we're just beginning to commission at Epsom St Helier now, and hopefully George's very shortly in the future. And I did have to Google it, because you have to check, because the 6 facets, they are 6 surveys. So I know we're focusing on condition, and that's a big part of it. But one of the 4th facet is the functional suitability review, which is the assessment of your existing space against what the existing HBNs and HTMs are, which is something that's also come out from CQC visits. So I think that will help us look at targeting those areas where we know that we have substantial gaps between the standards of today and obviously what was designed and built here in the 70s and similarly on other sites. So I think that is something we'd be able to pick through.
Yeah. Lovely, thank you very much, Andrew. So we're asked to agree to establish the committee, or the committees, review and approve the draft terms of reference, and review and approve the proposed membership. And as I say, my apologies in advance on that. Everyone happy to support those recommendations?
Yes.
Lovely, thank you very much. And that takes us on then to item 2.2 and the Public Sector Equality Duty Report 22-23. Paul.
Thank you very much. So the purpose of this paper is to demonstrate how we're meeting our obligations as a public body under the Equality Act, both in terms of specific requirements and general requirements. You'll see that the reports are quite different, and that's because each organisation needs to report as a statutory body on its own. What we would like to do next time we prepare this is to get greater consistency in terms of look and feel, but each organisation needs to report separately. You'll see that the paper covers a lot of our regulatory and legal requirements around things like gender pay gap, res, WDES, and a number of items such as that. It's broadly broken down into 3 areas. So the public sector equality duty itself, so what we're doing to meet that. There's a lot of work around, or a lot of information around workforce data, and also patient and service inequalities. Oops.
Sitting too still.
Information. It's a good summary document of everything that we're doing in a complex area. And what we're asking the board to do is to recommend it for publication.
Thank you, Paul. Any comments from colleagues? Martin.
So I very much welcome the report, and it does reflect the enormous amount of hard work and activity which is being done in this area. Whilst this is about meeting a legal requirement, of course we all are aware that the reasons why we're doing this stuff go way beyond that, and it's incredibly important to us. It's probably worth reflecting, because it's the public meeting, that one of the things we've been particularly focusing on in the People Committee is the need to try to focus on fewer things which are more effective. Because not just here, but generally, this is an area where, unlike a lot of other areas of hospitals' work, it's quite hard to get things that are evidence-based, and therefore it's quite hard to select those things that really work as opposed to activity. And I know that there's a lot of commitment to try to find those so that we can get more impact. Thank you.
Thank you, Martin. I think those points are really well made. I would also hope that over time we could get more of a standard format, actually, Paul. I do recognise that we're 2 different trusts. I'm very conscious of that. But the ESTH one in particular is very long, and I always worry about very long documents because people don't always attend to them in the same way. And there's still some gremlins in the text. So before it's published, someone just needs to take off. There's a few track changes still left with lines down the side. If somebody could just check that before it's put on the website or whatever. So if people are happy, the reports have been thoroughly reviewed at People Committee, as Martin said, and you've all had an opportunity to look at them. Are you happy to approve the reports for publication? Yeah, lovely. Thank you very much indeed. So that takes us on to items for review, and the first of those is the Maternity Services Report. Arlene.
Thank you, Gillian. So this report is really one of the reports that we should be bringing to the board, and it covers the perinatal mortality rates for both organisations. The only issues to draw attention to for the board are training, which we are still below where we need to be for training on both sides, but both teams have included a projection of where they think we will be, and both teams are confident where we are now that we will achieve the 90% for training that we need to be able to comply for CNST, but also to ensure that our staff have the training they need to deliver good care to birthing people. So that would be the only thing that I would want to highlight from this report. And one other is to say that one of the issues that has come out as part of our CQC visit to maternity in George's is the grading of 3rd and 4th degree tears. And we changed that process for both for Epsom and St Helier last year and for George's this year. And we will therefore be able to see here at this board, because those will be graded as moderate harm and then reviewed, downgraded if need be. but that is not included in this paper. It will be in the next board update. And I'm happy to take questions because it's all in the paper.
Thank you very much indeed, Arlene. And quality, as those of us who attend Quality Committee will know, we spend a lot of time on maternity for obvious reasons. Any questions or comments? Andrew, did you want to?
Well, probably just Chris. Worth me saying something, simply because we do look at this every time at Quality Committee, and obviously something we're really focused on at the moment. So the three big things for me are the perinatal mortality, which we're doing the external review on. Arlene's already referenced the training issue, and we're just keeping a close eye on that. And as you say, we've got a trajectory taking us to the right place. And the other one that we talk about a fair bit is staffing as well, which I know, following the CQC inspection, again, there's a huge amount of focus on to just make sure we get those levels right and understand in a bit more granular detail what's going on, because it's not just the total staffing numbers, but it's about having the right staff in the right place at the right time. But that's something that Arlene is very much into the detail of and working on.
Thank you, Andrew. I think we're all very grateful, Arlene, for the amount of effort that you are putting into this. I speak for myself, but I know others as well. So, Chris.
Thank you. I just want to, in terms of the mortality and morbidity data in maternity, do we do any mapping onto socioeconomic status or ethnicity? Because those are two things which do make a big difference on morbidity and mortality. And I can't quite find the right words to say, but it would be good to know whether we are outliers in some way on that, in which case that teaches us that we need to do something differently, or do we follow what that data would tend to indicate for those statistics.
Arlene, is it useful if I sweep up all the queries and then you can do it once? Thanks for that, Chris. So Jenny.
It just relates to the training issue about whether we're maximally allowing people to access that training. For example, peaks and troughs. Today, it was relatively calm and quiet. They're the moments where I think staff could engage with the training. And I think we ought to have a very proactive culture. It's lovely when they're not busy, but also we ought to facilitate that time. People are at work and they could complete it.
Thank you, Jenny Ann.
So I noted that the Quality Committee had given this limited assurance, and I wondered if we got a very clear idea of what needed to happen by when for us to get to a more fully assured position.
I think probably that latter one is for Andrew as the chairman of the committee. So Arlene may well want to add to that. But Arlene, would you like to deal with the first two queries and then I'll hand over to Andrew?
Yeah, so Chris, on the perinatal mortality, on slide 175 of 485, the ethnicity breakdown is there for all of the birthing people. So we do look at it from that aspect. What we're not able to do is to compare how well we are doing, or benchmark ourselves against others, because not very many people are measuring that yet. But we have started, and so the information is there.
Sorry, I was perhaps I don't think I was clear on it, but against our population of residents, does it map across to what we would expect from our resident population?
So in terms of the number of births that we have, it does. So we are not an outlier in terms of the number of births that we have against the perinatal mortality rates, apart from George's, where we said, against ethnicity, for the number of women of diverse backgrounds that give birth with us, the numbers are fairly even across the ethnic backgrounds. The George's Embrace review is on 2020, but I also need to say that the 2021 data is out, and George's are back within the 5% as well. So I think it's important to highlight that.
That is an important point. Thank you, Andrew. And Jenny's point about training?
And training, Jenny, I think, so yes, staff do use the opportunities when it is quieter The training that we're particularly concerned about and are reporting here is prompt training, which is multidisciplinary. So it takes some organizing to get all of the right people in the right place at the right time. So the teams are proactively building that into what they do. It's the fact that it's multidisciplinary is our issue.
I suppose the question that follows, Jenny, I don't know whether you were going to ask it, was where it is possible to be very swift of foot, where the training is more straightforward.
Yeah.
Is
Oh yeah, no, that is happening.
Yeah.
So that is happening. All opportunities are being taken. You know, if you have a group of midwives or a group of other staff, but it's the multidisciplinary bits that are the problems.
I don't want to prolong it, but that's my point, in that if that is becoming an obstacle and the staff aren't getting this, maybe we should just think a little bit about the moments or the other methods. I completely take it on board around the multidisciplinary and how complex that is, but we need to meet the opportunities and the reality of the work to try and...
I think those points are well made and understood. So Andrew, you'd like to deal with the limited assurance point?
Yeah.
Which was for one of the trusts.
Exactly, and really good question. I think we will feel more assured when we have the results of the Embrace data review. So we've said we needed that. Until we've got that back, it's hard to be fully assured around that. When we see the training numbers rise to where we want them to be, so we see that trend definitely going in the right direction. When we have the more detailed view of what's going on with the staffing numbers, so it's being delved into at the moment, I think when we see a report back that gives us a bit more assurance that we've got the right staffing levels and that they're deployed in the right place, that will give us more assurance. And then we've said we needed two further reviews of maternity, one around culture and one around governance. I think until those are we've said we needed them, until they're concluded, it's hard to significantly increase the assurance level.
That I can. I think it makes sense, yeah. Arlene, did you want to add anything? No? No, I said, did you want to... Sorry, I just wanted to make sure that you didn't want to add anything before I put the recommendation to the board.
No, that's
Okay, lovely. So we're asked to receive the report and make suggestions for any further action. I think there is a lot of action in hand. I don't think we want to be making, but we want to land the various elements of work that Andrew's just summarised. So people happy to support the recommendation? Yeah, lovely, thank you very much. So that takes us on to the Integrated Quality and Performance Report. Last board meeting, which of course was the first of us doing it jointly, we did get a bit lost in some of the detail of the IQPR, and it's really important that we talk about the right things, but we all know that there are detailed discussions in both Quality Committee and Finance Committee. So with that context in mind, could I ask James to introduce? Then I will do George's, then I'll do ESTH. Yeah, is that all right?
Thank you, Chair. So I was going to make the point that this has been reviewed in detail at both the Quality Committee and the Finance Committee. In terms of quality elements, I think a few key things to draw out are Quality Committee noted some ongoing challenges with infection prevention and control, and that we are not on trajectory or where we would want to be in terms of Clostridium difficile infection rates, particularly at St George's this early in the year. And we should note that there has been, for the first time in many, many, many months, an MRSA bacteremia at Epsom St Helier, despite this being an incredibly complicated patient. I think we need to note that we have had a spate of never events, and this report highlights 2 at St George's and 1 at Epsom St Helier, and they all relate in varying themes to wrong site surgery. Some positives on the quality element are some really good work in falls and some traction that we are seeing, some reduction in falls at all of our sites, and some improving parameters in the community too. In terms of the operational elements, elective care is very challenged. Industrial action has undoubtedly impacted, but it's not the only issue that is causing a challenge. And despite much work in outpatient transformation, particularly at Epsom St Helier, we are beginning to see a rising number of patients on our PTL, and we need to keep attention to that. And Epsom St Helier are receiving increasing challenges in the numbers of long waiting patients for definitive treatment, and a change in the reducing trend at St George's has been noted, so we need to keep our focus on that. I think we need to note the excellent elements of traction in diagnostic delivery, particularly at St George's, and a stabilising picture at Epsom St Helier. Continued excellent cancer delivery at Epsom St Helier, and an improving trend at St George's. For non-elective care, we've identified challenges with flow. We've talked about it at many of our committees, and we've talked about it today. And we're not where we would want to be in the numbers of patients who are waiting 4 hours or 12 hours in our emergency department. But lots of really good work happening, and we should note some of the improving ambulance handover delays. And then finally, on integrated care, we have been maintaining the 2-hour urgent community response. And I think it's probably on the basis of a good thing that we're seeing increasing referrals at the Sutton end. So more patients in the community are accessing urgent community response, which may be preventing an avoidable attendance in our emergency department. But we still have ongoing challenges with discharge on pathway 3, which is patients waiting for nursing home placement. So a few things to note.
Thank you, James. That's really helpful. Are there any general questions before I go? I'll do Kate, James, and then Thurza, so we'll deal with the 3 chunks. Are there any general questions or questions that went across both sites? Are people happy to wait until the specific? Okay, Kate.
Thanks, Gillian. I will be brief and just pick up some specific things. So in terms of emergency performance, I'm again not going to go into the detail of that, just to say that we continue with regularising flow at St George's. We continue with that battle, and it is a bit of a battle every day. We have had particular issues around mental health, patients in ED. That's been particularly challenging over the last 2 months. And we've had a really positive meeting with South West London St George's, and we've got some actions we're taking forward around prevention at the front door and a whole range of things, and us having visibility of section 136 suites, because we seem to be getting more patients coming to us who require that facility. And the third thing I was going to mention is we had a really positive system summit with system partners in Merton and Wandsworth and our community trust about 3 or 4 Fridays ago, and we've got a plan we're going to pull together about how we reduce waits and times that people spend in hospital. We've got something called the St George's line. It looks like a tube line, that's why it's been called that, which shows every sort of interface that happens when a patient's in the organisation, both right at the beginning and the end, but also opportunities for us to reduce time that people wait for things. So there's lots of good work going on in that space, but we know we need to bring our length of stay down. In terms of elective, as James has sort of picked out the main issues, I think our big challenge is industrial action. I think it's important for us to recognise we're about to go into more junior doctor industrial action, followed by consultant industrial action, and for us, followed by radiology industrial action. And radiology industrial action is pretty killing because we're so dependent on radiological procedures for so much of what we do. And though that covers 3 weeks in a row. So that gives me great fear about our elective programme, because we're just about keeping the PTL, as you can see, is rising, but actually we're sort of holding it. We're managing to reduce our 65-week waiters and keep that well below plan. A slight increase in our 52-week waiters, but it's a constant challenge. And I think that's a pretty good performance considering what we've been having to deal with in terms of industrial action. Theatre utilisation capped is around 74%, dropped slightly, linked to flow and a number of other issues, and also linked to the industrial action. But we are really working hard to make sure that we're dealing with a number of the issues that people saw today in terms of flow. One of the things that opening Holsworth will really help us with flow. We've been without that ward now for a year, so and that has had an impact. And there are lots of plans to work differently in that space. And diagnostics, as James mentioned, is a real positive. And then finally, cancer. We're doing reasonably around 2-week wait. We're sort of around 81%. We are we're compliant around faster diagnosis standard, which is good. That's something that fell off a while ago. We've kept momentum with that, and 62 days around 70%. Our backlog did rise, again linked to the industrial action, but we have brought that right back down again. So that's headed much into a positive direction again. But that's all I'll say. Thank you.
Thank you, Kate. So questions? Martin? Yep.
So just two things I wanted to mention. The first is that it doesn't ever seem to get much coverage in the media, but one of the impacts of the doctors' strike has been the way that the more senior nurses and the more specialist nurses that have been developed over the years have stepped up very significantly. And I just really want to take the opportunity to pay credit to them. I don't know if anybody else wants to comment on it, because people would be far closer to it than I am. But I am aware that a lot of very positive development has happened like that, and they've gone enormously to help to mitigate some of the worst effects. The other one, possibly sensitive, I'm not sure, but I just wondered with the radiographers, as you say, it's potentially a massive impact. Are we able to, is it feasible for us to buy in services from anywhere else? Or will it mean if we don't have radiographers that there isn't any radiography done? Thank you.
Thank you, Martin. Kate, do you want to deal with that?
Oh, sorry, I had my microphone on, apologies. So I absolutely agree with you, Martin, on your first point. I think we're really lucky to have fantastic specialist nurses and allied health professionals who do step up and step in. And we talked about that, didn't we, on our ward visit today, particularly in trauma and orthopaedics, because we've got great expertise here. In terms of your second point, I almost will defer to Paul. I think there's a limit to what we can do to buying in additional capacity. And there's also, you have to be careful about what you do during industrial action. I don't think there's going to be a lot of that available. It'd be interesting to see how many people actually take strike action, but this is the first radiographers' strike, so I think there'll be some momentum behind this one. I think that what we are seeing in strike action is more people are not wanting to take strike action because they can't afford to. So, but I think we're needing to work through what the impact is going to be, but my view is it is going to be quite significant.
Thank you, Kate. So I think I saw Paul.
Yeah, it was just a very quick comment
And then
to say...
Stephen Collier.
Yeah, very quick comment to say, legally we can. It's the practicality of it at the time, because everybody will be trying to get the same people. And I think we may struggle to be able to bring people in. It's certainly something that we should look at.
Sorry, just to clarify, I didn't mean bringing people in. I meant buying a service, which is different.
No, apologies.
From private sector or whatever providers there are.
I think even if there was availability, there's a question of money, isn't there? Because we certainly don't have the money. Stephen?
I'd just like to recognise the underlying improvement in our elective activity. There has been, and it's palpable in the numbers, a general tightening up in process and movement through. We are largely achieving targets even after some of the strike impact, and our ability to look at PTL and medium weighting, I think, should give us some hope, if not optimism, about the short term, about where this is likely to trend. And I think although we're very focused on the list and what hasn't yet been achieved, we should recognise there is some underlying good progress being made across the trust. Thank you.
I think the point's really well made, Stephen, and I suppose implicit in what's been said already is how well people have worked together, stepped up and all the rest of it. But it's been an enormous team effort, and I do think it's important that the board says thank you, because we are really grateful for, and we know it's really tough for the executives as well. It's not just the rest of the hospital. You guys have to run the hospitals, and I do want you to hear us saying thank you to all of you as well. I can't see any other hands on George's, so if I can't, James, over to you.
Thank you. There's not a huge amount additionally that I really wanted to highlight. I mean, I think you can see that we're continuing to drive towards improving our emergency care flow. We have a reducing number of 12-hour waits, and generally an improving position with ambulance handover as well, and are seeking to ensure that wherever possible we we get patients through within 4 hours, and we're largely tracking the 76% standard, which is the aspiration for trust for the end of the year. There's quite a structured programme of flow improvement behind that, so there's a number of working groups. I think a lot of it is about getting that sort of quality improvement methodology where we're focusing on the metrics, we're focusing on on cycles of improvement and understanding how we use a quality improvement methodology to sit underneath that, make sure that we're driving the changes and evaluating the impact of some of the changes that we're making. And I'd say that there's really strong staff engagement with that. I think if we can frame this as a quality improvement and a patient experience challenge, rather than simply a sort of performance and a flow challenge, I think that helps to engage people who are quite fatigued, frankly, by some of the challenges of the last few years. While I think that there are a number of positives around the elective performance at ESTH, I think there are, you can see some dark clouds on the horizon as well, and I think that gynecology is a really good example of that for ESTH. So we have 30% more gynecology referrals than we had pre-COVID, and we've gone from 10,000 a year to 13,000 a year gynecology referrals. And we do everything. So you can see our patient-initiated follow-up rates. Gynecology, they're really high. We do advice and guidance. We've done peer reviews with the GPs. We've trialled community clinics as well. And there's a big push regionally to start to move towards women's health hubs, which we want to be a part of. But notwithstanding that, we have growing numbers on the PTL, we have growing numbers of 52-week waiters, and actually in terms of our 2-week wait challenges last month, gynae was a significant part of that as well. So it's a really good microcosm of where going into that, obviously that's now affected by industrial action as well, and it's also affected by the fact that most places are seeing an increase in demand for gynecology. So when we try and lay on additional activity, the sort of market really for the workforce to do that, particularly on the medical side, has fundamentally changed. So as an organisation, we're trying to transform, we're trying to do things in a different way, we're trying to deal with increased demand, we're trying to maintain our performance, but we're also trying to keep our pay bill down, particularly in locum and agency. But we're actually finding that the unit price of the staff that we need to meet the performance and the quality challenges is going up all the time. So there's a lot of work we're doing, as I say, in terms of a system-wide looking at women's health hubs, looking at mutual aid between providers so that we try and equalise waiting lists as well. But I think it is worth highlighting that increasingly, I think, within that overall improving position, we will see some specialties, and community paediatrics is another one at ESTH, where there's a fundamental imbalance between capacity and demand, even when every single improvement action has been taken, and that they're going to be really intractable challenges that we're going to need system-wide action around over the next few years. So, there are many areas of improvement within this, but I do think it's worth highlighting that that we are seeing some of those fundamental capacity challenges, and everything that's going on around us at the moment is going to continue to make those really difficult.
Thank you, James. I think you explained that really clearly, and we had some good discussions in committees during this cycle on that. Are there any specific questions to Phil?
Thank you, Gillian. I mean, just to build on that, I thought you explained that really well, James. And as you know, I look at the 52-week waiters, particularly the, in fact, paediatrics, and I suppose if it is intractable, then we need to think even harder or more laterally as to how we're going to deal with this, because it's not just a matter of working harder, because it's not going to solve the problem. And I know there have been sort of system-wide discussions and with the various other sort of authorities, if you like, but it does seem that there are one or two things here which are just not going away, and I'm not quite sure what we do next, really.
No, I mean, I think that we have to continue to push on with the actions that we have. I think that within community paediatrics, we've seen, for example, really strong engagement now from our local authorities who have supported us to take a number of the quite radical actions that we wanted to take. And I think that that's with an understanding that if we were not in a position to take those and couldn't do that with their support, that actually that would leave us in a really difficult position as a board. And in some of the neurodevelopmental pathways, some of the adult neurodevelopmental pathways, other providers in South London have made a decision to close the waiting list. Now, we haven't done that and we haven't recommended that here because we're absolutely clear that, you know, with some of those services, we are providing an absolutely vital public service. And I think it's our job to take in the referrals that are appropriate and continue to try and see them as well as we can and transform the pathway and work it through. But that, you know, the issue for us, I suppose, as a provider is that, you know, we're taking that risk onto our waiting lists. We do 52-week harm reviews. We do everything you would expect in terms of surveillance with those patients. And for the community paediatrics, we've recently agreed some further actions with the local authorities to communicate with those families, make sure that they know that they should continue to access educational support even while they're waiting, in particular if it's for a diagnosis. But, you know, that risk is very much sitting with us as a provider, and other providers are looking at some of those really significant capacity issues and beginning to make a different set of decisions. I don't think we're at that point, but I do think that they are significant challenges, and, you know, it's something that we're going to continue to need to look at.
Thank you, James. Jacqueline, I think it might be helpful if you said a little bit about the system, because I think James has made it clear that, and as Phil put it, explained what we're doing, but you said a couple of times yourself, James, that about the system. So what is the system doing, Jacqueline?
So, I mean, the whole point of an ICS and an ICB is that we work together as a system between all providers, including social care. So, I think what James, I know that the IC, I never know which one to call them, the ICS, because I think with a B when we're sat together. The ICS actually is really aware of it, but the bit will be for me about, particularly as you and I sit on the board, about maybe pushing how actually we are connecting all this up, because it can't be that we've only got one or two services for children, for community paediatrics in the whole of South West London. So we probably need to pick that up. I think we are working pretty well together. Whether it looks when we're sat as acute trust, we can move some work around, and that's what we're trying to do with gynae. Trying to do some of that, as well as diagnostics into George's particularly, because we're doing so well. Because I think, you know, we have to keep the system bit going. I think we're trying to do the same with mental health, but I think we need something more radical than where we are and a lot quicker, because it really is becoming an issue. And we heard this morning about on one of the wards where we do get quite a lot of mental health patients, it's getting really difficult to staff.
Yeah.
So I think there's more we can do, but we're in a better place than others. But I think that we're not where we need to be, and I think we can bring up the paediatric bit more in the ICB.
But I think one of the reasons your work with the local authorities has been relatively successful, James, is you've worked really hard at it. You did it in exactly the right way. So I think it's a model of how to move difficult stuff on. I can't see any other hands to ask you questions, so I'm going to move on to Thurza and talk about community.
Thank you. And just, I think, 3 brief points. So the data now shows quite starkly for patients who are waiting admission to a care home, the difference between Sutton and Surrey Downs, and therefore the dependency there is on external partners and also the care home availability. So I think that's something definitely worth mentioning. Second point I would just highlight is that the Get You Better app, which has been rolled out across Surrey Downs, which is a self-care app for people who are with MSK, musculoskeletal problems, I think is our first entry into how we work with people and their self-care in a more systematic way. And it links into work that we're just starting on the back of the primary care recovery plan about how we ensure direct access to our community services without the need for a GP referral. And then thirdly, in July, we will be relocating our community hospital onto the Epsom site and integrating it with our acute frailty unit. I think that offers real opportunities, but without doubt some challenges, not least integrating the 2 workforces and the different cultures that we will have bringing the 2 together. But I'm quite sure we will work through that to a good conclusion.
Thank you, Thurza. So questions or comments on this? Chris, was there anything you wanted to say about community services, given you chair the two? No? Okay. That point about the care homes, is there anything that can be done, the difference between Sutton and Surrey Downs? I know it's a really difficult area, Thurza, but...
I think what we're doing is working really closely with the care homes to increase their confidence to take people from hospital. So we provide an in-reach service to care homes for anyone who's discharged. We admit people to the virtual ward. We held regular conferences with all of the care home providers of Surrey. So I think we are doing that piece of work. I think the second piece of work, which sits as much with the local authorities, is about how we change the payment regimes and recognise the increasing complexity of patients who are now being discharged to a care home and what that means for them. So those are the two things that we are doing.
So Surrey doing their bit there?
Surrey is always constrained at one level by the number of self-funders. So that we've recently had a scheme over winter, we had a scheme that we have continued where we're providing the same level of support for people who are self-funders as we do for people that are funded through the local authority, and supporting people in those decisions. I think Surrey are definitely looking at it, but I think it is slower progress than perhaps we would like.
I do understand the issues, yeah. James.
Just making an observation, as the Sutton Place exec for South West London ICB, I have been asked to sign off an absolutely unprecedented number of additional care funding requests on top of nursing home placements over the last 12 months. It's something that didn't really happen pre-COVID. I mean, if somebody went to a nursing home, they went to a nursing home. We're now quite frequently placing somebody in a nursing home and then putting in place either trained or untrained 12-hour a day, 24-hour a day additional support on top of normal nursing home staffing. And that level of complexity seems to be really increasing. There's very rarely an option, because the other option would be simply that somebody sits in a bed-based setting, and that is not the right thing to do. But it is definitely an increasing feature, and I think there isn't currently the market capacity in the nursing home sector for the very complex end at the level of demand that we're seeing.
But that's a Surrey County Council commissioning responsibility, isn't it? Or is it Sutton? Sorry, you said Sutton. It's a local authority commissioning responsibility. If the demand is changing, they should be working with the sector to commission the right kind of places.
I think that the funding tends to be split between local authority, CHC and self-funder. And I think fundamentally, if providers feel that they're going to struggle to get the certainty of funding but also the workforce, and I think the workforce is a massive constraint in that higher end sector. You know, they obviously having to compete with us for staff if it's nursing home as well. You know, they're having to compete with community services. They're having to compete in generally quite a ferocious labour market. And I think that definitely there's a job on every commissioner in that nursing home market to continue to try and increase capacity. But you have to have the willing providers, and there is definitely more risk aversion in the provider market. So I think it's just a really complex challenge.
It is, and not for us to detain ourselves here, James, but I always get worried about public services doing what they've always done. Because if you do what you always do, you get what you always got, kind of thing. So I can't see any other hands for any part of this report. So we're asked to review it, which I think we've done, and note the information it provides for us. Is that okay? Thank you. And that takes us on then to item 4.3. I've got double numbers here, which is very confusing. But anyway, the finance report. So Andrew, over to you.
Yeah, I'll keep this reasonably brief. We're 2 months into the year, so it's let's call it the easier part of the year. So the fun really begins as we move certainly into the second quarter. But at this point of the year, we are on track with plan, which is encouraging. The key variances that we're seeing, which are relatively minor, around ERF and industrial action in terms of the impact, and they are being classified as what's termed as an allowable miss, if I use that phrase. So the NHSE allow us to report those as an adverse variance, and they will accept that at this point. It is unclear how those two things will ultimately be treated, and we're waiting for guidance on that. And they are quite intrinsically linked in many respects, because industrial action will limit our ability to deliver the activity that we need under ERF in terms of the elective recovery. So we need to watch that space. But at the moment, as I say, they are allowable misses. The rest of the issue is on plan. I think it's worth calling out, you know, as I said at the start, this is very early. There are pressures building, certainly from some of the activity pressures that we've just discussed, but we mustn't mention we have significant CIP plans, and they are largely phased to start kicking in from month 3/4. So we should expect our position to become much more challenging and indeed challenged as we progress.
Thank you, Andrew. I think we're all very conscious of that. Any questions for Andrew or comments on the financial situation? Martin?
I was just wondering, do we know how the financial impact of the consultants will compare to junior doctors? Sorry, I mean the industrial action.
Give it a go, Martin.
Yeah, I can. Well, we are monitoring, you know, they are separate, distinct events, and, you know, we can monitor the who we pay to what, basically, during each of those events. So, you know, so we can track the payments that go through. So yes, we will be able to pick that up. I think it's worth pointing out that that's quite a complicated set of metrics, because there's not just the cost you incur, but there's the things that don't happen in terms of activity that's not completed, etc. And indeed, you know, we were just talking through an issue yesterday with some partners in South West London. So if I take, you know, the interesting ways it plays through, we have a profit share arrangement around the South West London elective orthopaedic centre, but actually that's largely elective work, so that profit share will be impacted by industrial action and our failure to deliver ERF. So again, we need to rope all of those things in. So I think you'll find that's an evolving piece of work, but we are establishing processes to do it. There's also some national work ongoing in terms of how they would expect us to value the impact of those. Did feedback some comments on that. I think for here, it needed a little more work, if I put it in those terms. But we will try and engage and influence that in terms of how that plays through as well.
Thank you, Andrew. Arlene, I wasn't sure whether you were just scratching your head or indicating. Yeah, don't move, because otherwise I'll call you. Kate, was there anything you wanted to add?
I was going to just add that I think the big difference between the two is we have got a sort of rhythm of being able to do a reasonable amount of activity when the junior doctors are striking, but it's very expensive because we're paying consultants to do most of the work. With the consultant strike, we will have to ramp right down what would be Christmas Day level services, which means our elective impact will be enormous. And obviously there's a cost implication not hitting ERF, although we think ERF might go out the window with all of this. But yeah, so it probably won't cost quite as much, but the delivery and the income opportunity will be reduced significantly.
Okay, thank you. That's helpful. Is that okay, Martin? I think that's covered your query. I can't see any other hands, so we're asked to note this paper. Happy to do that? Lovely, thank you very much. So that takes us to item 3.4 and the group strategy oversight and implementation. James.
Thank you, Chair. Apologies, there's quite a lot of information in this report.
No, it's a good report.
So it's 2 months since we launched the strategy with the organisation and our external stakeholders. So this report provides an update on the launch, the mobilisation and our next steps. In terms of the launch, I think there's some data on pages 293 and 294 that provides information in terms of the level of engagement that we've achieved. So 4,300 of our staff have read the email that you and I sent out to all staff. That's quite a lot, but we do have 17,000 staff. More than 2,000 people have downloaded the full document, and 1,000 have downloaded the 2-page summary document. So hopefully the summary document is providing something that is more digestible, that can resonate with people. There's definitely more work that we need to do to promote the visibility of the strategy and embedding this from board down to ward level. I think at executive and senior leadership team level, there's certainly good resonance about the strategy and the understanding about the corporate objectives, and our chief operating officers at both trusts are now developing dashboards relating to the care acrostic and the objectives to work through with the divisions and the services about how can we get visibility in terms of our delivery and progress, and to use through the interface meetings that the divisions have with the site leadership teams about how we can embed a quality improvement methodology and approach to supporting the progress against those objectives. In terms of mobilising the strategic initiatives, each of the 9 strategic initiatives have a named executive SRO, which is documented within the paper, and there's some resource from the central PMO function aligned to help the mobilisation of these strategic initiatives. We're currently scoping up the breadth and governance of each of these initiatives, and the paper highlights the independent PMO's assessment about the progress with mobilisation, and that's documented in the RAG-rated charts. Over the next quarter, we absolutely recognise we've got more work to do to better define all of the themes within these initiatives, identify all of the enabling projects and programmes, and explore the interdependencies between these initiatives, and refine the governance to ensure that we can be assured on our delivery of these. Crucially, and we need to make some progress on the corporate enabling strategies that underpin a lot of this work. And we previously agreed at the board that we would do this work over the course of the next year. And there are 6 core corporate enabling strategies: digital, estates, sustainability, quality and safety, research and innovation, and people. The report highlights our proposal for how we aim to progress the delivery and some of the governance of these corporate enabling strategies, and we'd aim to bring an update to the board in September, but also to utilise board development sessions to review emerging themes and questions. So it'd be helpful to receive comments and thoughts about the group strategy and the board's view about the proposed timeline and the governance for developing the corporate strategies.
Thank you, James. I did think it was a really good paper, so thank you. I think it sets it out very comprehensively. Phil, and then Peter.
Thank you. And I completely agree. I think it's an excellent paper. And I think the whole piece of work is an excellent piece of work. And I suppose my one comment at this stage is that have we determined what the sort of lift conversation is? If you're caught in a lift, James, with a nurse, a doctor, and a porter, what are you going to say to them about the strategy? And I just think it'd be really important if we all had that piece. So high-level comms, I think, is really important with this sort of strategy. So I think if that's there, that's great. But I think it would be great if this whole community could practice using that, because there's so much power in what we've created. We now need to really communicate it in a really simple way.
Thanks. Shall I take the questions, James, and sweep them up, and then you can respond? Peter, and then Chris.
Thank you. And again, I welcome it too. Just picking up the one strategic initiative, which is RAG-rated as red, which is transforming our culture, and which is under Arlene's leadership. I just wondered, a number of mitigations there or next steps, but how quickly do you think we're going to get back on track to amber and beyond? Just are you confident we'll do that in a reasonably short shift?
Thank you, Peter. Really good question. Chris?
Thank you. It's on the programme regarding collaboration across gesh. I was thinking this in clinical matters, but actually it could apply to any role across the two hospitals. How much consideration is there to getting ideas from the shop floor about how working, with, if you're at Epsom St Helier, with St George's or vice versa, could improve the work experience that people have and their career development, and hence potentially their retention and work satisfaction in the trust?
Thank you, Chris. Another good question. Any more for any more? No? Okay, James, over to you.
I'll pick up Phil's and Chris's questions, if that's okay, and maybe ask Arlene to comment on the culture, diversity and inclusivity strategic initiative. So Phil, I think you're right. There's more work to do to sharpen and crispen the lift conversation. We have developed one-page posters. We want to make sure that as we firm up the detail of the strategic initiatives and how they're going to be implemented, that we have something that is really tangible and credible and not abstract. I think in a number of pieces of work and programmes, we don't want to create an air of cynicism that this is sort of hanging to one side and not embedded within our day-to-day ways of working. So it's work we've got to do, and we need to engage with our staff, and the comms team have got some great ideas about how we can get higher visibility and promote the conversations right through the organisation. And we'll definitely work on feeding and messaging key successes and deeper dives into these initiatives as they materialise.
James, sorry to interrupt, but before you move on to Chris's, Jacqueline just wanted to come in on this. Will you say any more on this point?
Just to say that I think that the key message is defining where we want to be in 2028 and framing the conversation around that.
And I think the quality improvement bit has a big part to play with this, because as we roll that through and people start doing huddles and we measure what we're doing, we should also be explicit in measuring what we're doing as part of the strategy on a quarterly or 6-monthly basis as part of the teams. And where they do QI best, the bit about the strategic bit is part of the feedback loop, not just the day-to-day how are we doing in the various areas. And I think that has a big part to play. And just a small additional update, when James talked about 4,000 internal, that's only St George's because that's the only place we can measure. So until we roll Jenna out across the group, we can't get that from ASTH. So sorry, James.
So it might be more.
Well, it is more then.
Back to you, James.
So that makes me feel warmer. That's a warm bath moment, isn't it? Just picking up Chris's comment about the collaboration within gesh, it's really important that it's not a top-down process. Each member of our organisation needs to get a sense that they are owning the agenda and helping to shape it. We have identified some potential opportunities for clinical integration. We'll be talking about corporate service integration later on in the board meeting. And our general approach now is we're trying to chunk up our clinical services into about 10 groupings so that we can promote those conversations between clinical and operational teams across the organisation, supported by senior managers, so that we can have an organic understanding from the ground up as to where the variation occurs, where the opportunities for collaboration and mutual challenge and learning occur, but to be supported by managers to keep a focus on where we're developing. And in 23-24, we've identified 4 key areas where we want to accelerate these clinical conversations. So they're in surgery, in some areas of paediatrics, in medicine, including frailty and renal, and in some of our clinical support areas. And I'm very happy to provide more detail if that's helpful, either in this meeting or offline.
Thank you, James. That's really helpful. Did you want to come back on any of that, Chris? No, thank you. I think we would like to hear more about those specifics, not necessarily today, but at some point, James. So just think about the best time to do that, really. So, Arlene, are you happy to take as SRO the question on culture?
Yes. So I think I'd like to start by saying that I am committed to ensuring that we do this work on transforming our culture. As a corporate service group chief nursing office, we've been a tad busy in the last couple of months trying to sort out maternity response to the Section 29A. So that's why this hasn't moved forward. Now that we have submitted those responses, not that the work has finished, but we will be picking this up again. And I'm working to try and increase the number of people that work in the group chief nursing office as well, so that will help. And we've now got Steph who is back and fully working, so we will be able to pick this work up. When will it go, Amber? So it should go, Amber, by the next time we report here, but definitely working towards green.
Thank you, Arlene. Paul?
Might just be worth also just making a point. It's not that nothing's happening around culture. I think that's a really important point to make. So whilst it's showing red, we're doing an awful lot of work already behind it. And so I think it's more, and this isn't an excuse, it's more about almost this piece of work around culture. What I wouldn't want and wouldn't be fair is for people to think that there isn't anything happening. There is.
And I think the People Committee sees quite a lot of that, doesn't it? Yeah, okay. Any other points people wanted to raise? So I think we're noting the update. I think several people have said what a really good piece of work it is, James. I hope you heard that, did you?
Thank you, and I'll feed that back to the team.
We've, in doing that, I think, reviewed the proposed approach to developing corporate enabling strategies. Well, we've heard about it, and none of us seem to unhappy with what we heard, James. So people are happy to support that. We are going to move on to items 4 on the agenda, which are the items for assurance. And we're going to start with the Quality Committee, and over to you, Andrew.
Thank you, Gillian. So I'm reporting on behalf of both myself and Aruna. So Aruna unfortunately can't be here, so I'll report on behalf of both committees. The key things we wanted to flag up in the report to the board were, first of all, maternity services. Now, we've already had a big discussion about that, so I don't want to go through that again. The second item was around mental health patients in the emergency departments. Again, we've had a discussion about that already, but we did have a big discussion at Quality Committee around that, so we wanted to flag it up. The third item was serious incidents, and the issue was that there have been 2 incidents at St Helier in the renal service where patients really tragically died from venous disconnection during hemodialysis. Because there had been 2 incidents in 1 year, we thought we should highlight that. Now, there are actions that have been agreed to deal with that and to mitigate the risk of that happening in future, but until we'd seen those actions completed, we're keeping a watchful eye on it in Quality Committee, so we want to hear back that those actions have been completed to give us assurance that the risk has been properly mitigated. The final thing that we flagged up in the report was infection prevention and control. Now, you've got the item for noting under 5.1, which is the full infection prevention and control report. I guess that the thing that had made us feel less assured was the fact that we were seeing already at this point in the year, after 2 months, the C. diff infection rate, Pseudomonas at George's and E. coli at George's, already tracking well above what the trajectory should be for the year. And I guess particularly with Pseudomonas and E. coli, when we also see that the mandatory training isn't quite where it needs to be around infection prevention control, it's hard to feel as assured as one would like to be. All I'd say at this point is we'll just keep a watchful eye on it in committee. It's early in the year, so we just need to see what happens with that, but it's something we're paying attention to. We mentioned the governance review as well, but that's been picked up in our discussion on maternity. So hopefully that gives you a good summary of where we're at with Quality Committee. Happy to take questions.
Thank you, Andrew. Any questions from colleagues? No? Can't see any hands.
Can I ask it? Sorry.
Yes, you're allowed to ask a
I was in
question.
and out of quality security a little bit. Why do we think, have we got the root cause, apart from, I mean, training obviously, but there'll be more than just training, I suspect. Do we know any other environmental factors or any reasons why we're tracking so highly above those rates?
I think that's one for Arlene, really.
Yeah, I'm looking at both of you, but
Yeah, well, I think on a specific like that, it's for Arlene.
So the reports, the full report is there, but every single case has been reviewed to identify any lapses in care. So we know training is an issue and we need to sort that out. And no, there's only one case where a lapse in care has been identified for C. diff. The rest of them, not so. There is work going on around antimicrobial prescribing, which we feel is one of the issues that we know that we need to deal with, and the team are pulling together almost a deep dive or a look at what we're doing around antimicrobial prescribing. So the answer is all the cases have been reviewed. There have been no huge lapses identified in terms of practice or even environment that have contributed to it, and the work continues to ensure that they're all reviewed. I do also have to say that it is not uncommon for these to track above trajectory at the start of the year because of the seasons, and even in the last data that I've seen, they've moved back into the range that they would be expected. So I'm not overly concerned. They will do that. But at this point, I wouldn't be very concerned. But
it was as much about the environment, because sometimes we look at the care, but we don't think, well, they're all from X ward or the next building. That was the point.
So the environment, because at Epsom St Helier, we do have environmental audits, and on all of the areas where we have maybe a couple of cases, they will do an environmental audit. Those environmental audits haven't picked up or anything glaringly obvious that we need to deal with. So those are happening as well. George's, it happens as part of the ward accreditation. So the environments are being looked at.
Derek.
Can I just say that under Andrew and Aruna's leadership, the committee has become much more proactive. And I wondered if, Andrew, you wanted to say any more about the programme of deep dives that's being planned. I didn't hear it, but maybe I missed it, sorry. But I think that's one of the really good things, to be proactive and not looking for problems, but looking for ways we can improve quality. And I think the deep dive programme is a very important contributor to that.
Yes, so we have had a few discussions around the deep dive programme. I think we took a bit of a step back because we had deep dives planned for every month. And I think we were just questioning whether that was the way we wanted to do things. We felt that slightly less frequent deep dives, but focused on the issues we really wanted to look at, would allow us to dive in more detail into those areas, but also have the opportunity then to hear back around progress and actions taken as a result of the deep dives, rather than just churning through new ones. So that was quite important as a principle. There was also we've also had a discussion around when do you deep dive into something and when do you just recognise as an issue and just need to see actions taken to address it. And when we flag up an issue, putting a deep dive into 6 to 8 months for that area is probably not the way we want to do it. We probably want to say, we know we've got an issue, so let's fix it and let's be assured that we're taking the right actions. The deep dives are more about things where we want to really understand what's going on, or if we want to just check about an area and we're not sure whether there's an issue or not. I think that was the crux of the discussion. Does that sound right, Derek?
I think that's helpful. I hope you do too. Thank you.
Thank you, Derek. I think it was a good point to raise. I can't see any other hands, so I'm going to take Chairman's prerogative, because we're on time at the moment, to say the other area that certainly I still feel anxious about, I think others in the committee did, is how PSURF is going to actually work in practice in terms of what comes to Quality Committee. That feels still like a very grey area to me. I don't have a sense of that. I'm not sure anyone can answer that problem for me, because it's work in progress, isn't it, Andrew? But I don't know whether you wanted to say anything about that.
I think that's right. I think we're just going to have to continue to reflect as that's implemented and we start to see how that works through. We're just going to have to keep reflecting on that and checking ourselves about how it's working and whether we're seeing what we think we should be. Would you concur with that, Arlene?
So I think we just have to wait and see, because there are different methodologies and different, but the test will be, do we get to see what we feel is the right things at Quality Committee, and we will start bringing, those will start coming through in August. Well, it's for committee in September.
Yeah, well and perhaps when I see something, Arlene,
Yeah,
I'll feel less worried about it. James?
I think my reflection, and I think it's been a reflection about site level governance, but I think it's the same for the committees and the board, is that the action plans, the organisational action plans that are driven by the key themes arrive at, the more thematic approach with PSERF, instead of focusing on individual incidents, you kind of aggregate up, look at your key patient safety risks, and that really drives those action plans. I think those action plans are going to be incredibly important, and I think that those action plans need to be incredibly smart, they need to be fully resourced, they need to have really strong organisational commitment. So I think that whatever we do, I think we need to build really robust assurance around those action plans in, and I think that would be where I would centre a lot of it, knowing that there will need to be some more sort of technical details around the grading and the management of incidents at Quality Committee as well.
Thank you, James, that's helpful. Andrew and then Richard.
So I guess just on that theme, James, it very much ties in with what we were saying around the deep dives, which is, we will be looking more thematically, we'll be looking for action plans, but creating some space to then check on progress on the action plans, because I think sometimes there's a risk that you create an action plan and you think job done, but we really need to be tracking. I think that's what we've learned a bit through maternity as well. We need to be tracking to make sure the actions are being delivered when we said they would.
Thank you, Richard.
I think the approach that Quality Committee can take is to ask itself a set of questions that PSERF is meant to deal with. One of the most obvious areas of uncertainty is that at the moment we have a clear definition about what kind of incidents we take to Quality Committee, because they're defined as serious incidents, and we're given much more freedom through PSERF to look at what we want to look at. So I think Quality Committee will have to ask itself, do we still feel confident that we're seeing the most important incidents that do happen, so that we can recognise quality issues when they occur? But also, are we getting assurance that the approach to these incidents is intelligently systematic and thematic? Are we getting assurance that we're actually mending and improving and restructuring things when we need to? But also on the cultural front, a lot of PSERF is about making sure people don't blame staff and people feel free to raise concerns. So I think we'll have to think about ways of triangulating assurance that we're improving our culture in terms of staff feeling comfortable raising concerns, and that we're looking after our staff when they are involved in safety incidents. We need to do some thinking about how that assurance gets structured, but I think that's what Quality Committee should be looking for.
Yeah. And that's helpful because it kind of codifies my anxiety, if you like, if that isn't a contradiction in terms. But anyway, thank you for that. I can't see any other hands, so we're asked to note the Quality Committee report. People happy to do that? Thank you. That takes us on to the Finance Committee report. Anne.
Thank you. So, given its position on the agenda, we've talked about quite a lot of what's in the Finance report already, so I won't go through that. The Finance and Performance Committee is an incredibly busy committee at the moment, as it covers money, performance, IT and estates. And given the decision earlier, we will need to now relook at the terms of reference for the Finance and Performance Committee. But one of the things I hope that will do is to take some of the pressure off, because although we get through it, it's a bit of a marathon, isn't it, to get through all of the items in the 4 hours, and probably to do a bit more justice, because I have worried that we haven't spent as much time on particularly on the performance stuff, as I'm hoping we will now be able to do. And of course, we've already talked about performance, and we did talk about that in the committee. And of course, it's always difficult, isn't it? Because it's like eating a herd of elephants. It's not just one elephant. There's just so much to do that when we say we take reasonable assurance that people are doing well, it's in that context. That's not saying everything is being done. It's just that we are doing incredibly well in really difficult circumstances. And of course, the circumstances are more difficult this year because some of the levers that we might have pulled in earlier years, like bringing in more agency staff or just more staff, aren't open to us because of the financial position. And that has impacted. And so one of the issues we wanted to raise was around agency rate cards, because it's not just the number of agency staff, but the cost of those agency staff. And that's something that we will need to take up at a system level, because that will have a big impact on our budget. Equally, and we've talked about it already, the industrial action. We recognise the huge amount of planning that went in to trying to maintain activity during the first rounds of industrial action. And obviously with the proposed consultant strikes, that becomes even more difficult. I think Kate referred to it as a sort of Christmas Day service. And again, not only is that an operational really difficult issue, but it hits us hard in the budget as well, because it means we won't be able to do some of the elective activity that we had planned. And almost the only way you would do that was to spend money to do it differently, and that's money that we don't have. And whilst we recognise that all of our staff are working incredibly well, we were particularly exercised about the pressure on general managers in the hospitals, and wanted particularly to point out, that we've recognised their dedication and commitment, and that we appreciate the difficult position they're in. That's not to say others aren't, but they are sort of squeezed in the middle, aren't they, of trying to do lots of things. We've also talked about the attendance of patients with mental health issues in ED, and I think there's a performance issue there as well as a quality issue, and we said we would come back to that. We've already talked about the money, and Andrew said that we're on plan, but we have a challenging plan this year, and actually the report does refer to the finally agreed deficit positions for both trusts. But that does require us to develop some quite ambitious cost improvement plans. My sense is we are ahead of where we were in earlier years, but we have a bigger target. And as Andrew says, that is going to ramp up, particularly in month 4. And we know that we'll need to really keep on top of that, because if we don't deliver those savings in the right time in the year, then it becomes yet more challenging to deliver them later. And on that basis, we have agreed that we will meet in August, because that will be when we get the month 4 figures. So it kind of feels like we're holding our head above the water, but it's quite choppy, I think would be my sense of it.
Thank you, Anne. That's very nicely put. Any questions to Anne about the committee? No. Mainly, I think, because we've covered it during the earlier parts of the discussion. So we're asked to note that report. Happy to do that. Thank you. That takes us on then to the People Committee report, and that's you, Stephen.
Thank you very much. I won't read the report. We could be here for some time. And I'm sorry that it's escalated to 14 close typed pages. Martin adverted to it earlier, but one thing that we as joint chairs want to do is to have fewer things in more depth. And at the moment, you'll see from the report, we have a set of compliance, regulatory and governance process things that we are managing or giving oversight to. And then a set of far more critical people, culture, HR performance oversight areas, and dialing up the latter and perhaps dialing down some of the time we spend on the former is an objective for us. The report is very comprehensive. I did reflect on whether it would have been shorter to send both sets of minutes out rather than put them into a report. But I think we will come back with something which is shorter and probably a bit more focused for you. But there were 4 things I thought I'd usefully pull out, particularly because they go to the assurance function we have. So firstly, there is a reference in the report to a deep dive on recruitment and retention, and that doesn't quite do justice to the management response, which did give a strong assurance around how actions and programs are underway and being initiated to improve our retention of staff. Secondly, it's encouraging to see the grip around the workforce improvement plan. It's not the quantum of efficiency saving that is developing, but it's seeing HR and finance and operations working collectively together on delivery, and that gives us a lot of assurance about the way, particularly some of the SIP plans have been well thought through. I'll mention freedom to speak up. Cases continue to rise, but importantly, the proportion of cases that deal with patient safety is also beginning to rise. So freedom to speak up being used in the way that was originally contemplated, as well as for an opportunity for staff to raise specific issues. I'll mention briefly that the committee has had oversight of the bank insourcing at Epsom and St Helier and watched the morphing of the relationship between the two trusts. I think there's a microcosm of some of the issues that will be, I think, effectively managed when we come to group integration, but they've come through, I think, very well, and we've been very pleased about the way the executive has thought about the relationship between the trusts for overall group benefit. That has come through strongly and well. And the final point is, with an eye on the compliance assurance role, there's the national minimum wage question in a particular subpart of one of the trusts, which we'll talk about in the private board. But again, it shows the range of areas that the committee's been looking at. And obviously, I'll be very happy to take any questions and pass them to Martin to answer.
Well, I was actually going to ask Martin if there's anything you wanted to add at this stage.
Yeah, just one, I think, partly because it hasn't been raised here before, and that's the question of policies and out-of-date policies. This has been going on actually for several years through various changes in management, and it is a huge amount of work, and clearly there's been so many more urgent priorities, COVID, industrial action, etc. But I think it's worth reminding that it does cause practical problems for people if policies are out of date. Certainly it's been raised to us by freedom to speak up, it's been raised to us by line managers being unclear. And it's beyond the scope we can cover here, but in a way it is a feature of the NHS in the way it's organised, because if you take a step back, our policies don't really need to be very different from other policies of similar organisations. But in reality what happens is, firstly, we have an enormous number of policies. Secondly, somebody rewrites it, and then thirdly, there's a very lengthy consultation process with the staff side, which is all good. But the reason for mentioning it is, part of our role is clearly to challenge in a constructive way. And we did suggest at the last committee that it might be an opportune time to rethink about whether or not what I've just described is the only way we can do things. Because to be honest, it's going to take years at this rate, and it's perhaps we need to think about a different way of doing it. And I know it's more complicated than that, but one example would be that there are model policies that have been created, which there is an argument to say could be dropped in, which at least would help with some of it. I know there's reservations about that, and there may well be a better idea, but I thought it was worth flagging it. Thank you.
I agree with that, Martin. I think your point about it'll take years if we do it the way we've always done it is absolutely right. Okay, so there's an awful lot in all of that, and we've got a lot of hands. So, Phil, Yin, Anne.
Thank you. Just two short points. One, I completely agree we should do less in the committee, so less is more in this space. But I think there needs to be some triangulation done with all the initiatives that are going on before we get to less is more, because I think there is probably some overlap and there's probably some gaps as well. And if we triangulate some of the things that we talk about, I think we could probably reduce the amount of work, well, reduce the amount that we review and get assurance about in the committees, and we can probably provide more advice and help and support in the areas which are really most valuable. So I think there's a piece of work to do there. The other thing, just to build on what Stephen said about freedom to speak up, I think it's probably both worth mentioning that both guardians were concerned sometimes about the length of time it takes to resolve the issues that are raised, and they both raised it, and it's in both their reports. They were very both very positive about how they're working with the site teams, etc. But some things seem to get stuck, so I think that's something we need to be aware of then.
Well, I think it's more than we need to be aware of. We need to see a change in that, and it might be helpful if, when we get some comments, Jacqueline says something about that, actually, if you don't mind. Thank you. So I'm going to take all the comments and then respond. Yin.
Yeah, I just wanted to ask about the ethnicity pay gap report. That's page 334 of Diligent. It said that there was a spotlight on senior staff and identified a trend of significantly less ethnic minority staff in senior roles, recognizing that it reflects the sort of national picture, so it's not just the sort of two trusts here. I just wanted to find out, is there going to be sort of standalone, I mean, it does say that there's not going to be a standalone action plan, and it will be assimilated into the workforce race equality standard. But I just wonder whether by doing that, it might almost get lost amongst all the various actions. Thank you.
It's a good challenge. Anne.
Thank you. So I was going to pick up the points about the freedom to speak up reports as well, because they raise some quite worrying issues, don't they? They talk about management conduct, bullying, harassment, people suffering a detriment for raising concerns. And so, I mean, this was the annual report for last year. And my thought is, are we satisfied that all these issues will be picked up in one or other action plan and addressed? Because they're of quite concern, aren't they?
Indeed, Anne. James, I'm so sorry, I just didn't see you. I did see you, but I didn't see you indicating.
I just wanted to come back on Ian's challenge, which I think is a completely fair one. So I think in terms of just linking together what we've committed to in terms of the group strategy, and also the culture change work that we're doing, and responding to the staff survey and the diagnostic, for ESTH, in terms of looking at our scorecard, our site and our divisional scorecard, we've actually put the ethnicity and progression above band 6 metric in, and asked for it to be broken down at divisional level. I think that it's incredibly important that we start having a conversation which is not just an organisational conversation, but actually increasingly a divisional and a service conversation, to say, actually, where are the challenges in terms of progression, and how can we support services to be more proactive about talent management and identification within those areas? And I think it is a RES metric. It's a really important RES metric, but I think with all the RES metrics, what I increasingly feel we need to do is really stop seeing them as just sort of global metrics and take them down into organisations and have really live conversations with our services about them. So it will be the first year of us doing it, and I think that will give us a much deeper understanding, sort of area by area across the organisation, where we have challenges and what effective strategies look like to support people with that progression piece. So I think it is something that we've recognised and are looking to get a deeper understanding and more detailed actions around through that approach.
Thank you, James. That's helpful. I mean, Martin has regularly made the point over the years that, you know, you've got to get down into the divisional bits if you're going to change some of these things. Yes, there needs to be some corporate action, but you don't achieve very much that way. And it doesn't just apply in this area, it applies a whole host of other areas. So it would be good to know what the George's position is on that, so that we can so that Yin's had a decent answer. She's heard about ESTH. So who's going to talk about what's happening at George's in relation to that? Paul, you
Just
want to?
as a general point, it was a very deliberate decision not to have a standalone action plan around the ethnic minority pay gap. And the reason for that is exactly the point that we've been making, is actually we've got lots of plans with lots of things, and there's a real danger that we end up just replicating here. If you look at the gender pay gap, we have got a plan which is very, very specific. We got the RES action plan, which really deals with how we get people into more senior roles, which is the issue around pay. And so it was quite deliberate not to do something which replicates. If you look at, without going into too much detail, one of the issues you've got is just if you just look at our local area, and you look at more junior roles, they tend to be filled by people more locally. It tends to be a higher ethnic minority area. So George is part of the reason we've got that compared to Epsom St Helier. It's just a local demographics in some respects, and your more junior staff don't tend to travel as much, and therefore tends to reflect the area. There's much more that we need to do, and that's a whole big piece of work around how do we get more BAME staff into more senior roles. But I just wanted to make that point. It was a very deliberate decision not to have a standalone plan, for the simple reason, like I say, I think we capture it elsewhere.
And I think that's absolutely fine as long as we're assured about the other activities. So we've heard very clearly about ESTH. So you're going to talk about George's, Kate?
Yeah, I think James's point is really well made, and the need to get down into divisional level and service level, because it's about progression right the way through that gives people the opportunity at senior levels as well. And I think we will do something similar to make sure that we're tracking that with the divisions. We're looking at staff survey results generally and actually breaking that down into greater detail around divisions and teams that are happy and teams that are less happy. And this is just actually a more rounded view about all elements of at different levels of the organisation within services and sub-services. So up to.
Thank you, Kate. Certainly when I talk to the staff support groups, the point they make over and over again is about developmental opportunities and fair recruitment in order that they can make progress. And it comes up over and over again. And it must be tiresome for them to have to keep raising it, making the point, because and it's not that we don't hear it, but we just don't kind of see the progress we would like. So I hope, Yin, that's given you a degree of assurance around that. If Phil, so there's two areas I think we still need to kind of land. There's Phil's point about triangulating and getting to the less is more so that we're confident we're focusing on the right things. And then I think we need a bit of a discussion about freedom to speak up, actually, because both Phil and Anne have raised it, and there was a very detailed discussion at People Committee. I think the kind of points that you've both made were widely shared. So who's going to deal with the triangulation point and the less is more?
I'll do some of that.
Will you? Okay, thank you, Jacqueline.
So one of the things that I suppose, but I was going to say this in part two, but I'll say it here, born out of some of the maternity CQC stuff, was that we don't have the overview on quality and people at execs that we do on performance and money. And we need to change that, and we've agreed collectively how we're going to do that by beginning to bring all of that up to exec level, because at the minute it happens at site and then it sort of goes round the exec to the board often. So we need to have that, and then through that then the exec meeting being able to triangulate across all those elements so we can spot areas. And it's not divisions often, it's actually service areas where actually corporate or clinical, where things aren't going right, because you often know when you see high turnover, high sickness rates, high complaints, things that cross all of us that actually you need to go and have a look there. And then when you see the staff survey, we go, oh, look at that, we never knew that. But actually, we could have probably told that when we actually looked at all of that. So we need to find a way of putting a tartan rug together that actually crosses all the domains. So, where money's out of kilter, where turnover is high, where quality is going down and they're bronze rather than gold, all those things actually, and all the people metrics. So that is the plan. It's going to take, and I've given us till September to implement that plan. So it won't be easy, but we need to do that, Gillian. And I think that links into freedom to speak up as well, because I don't always have the visibility until something hits my desk because a member of staff has emailed me, or we see the freedom to speak up stuff to know actually where some of this is. So it's only it sometimes feels we get to know later rather than know earlier. And I think there is something about what is the process and for whom is it? That it's not that I get an email because somebody who said I've caught freedom to speak up and nobody's done anything. And how do we get into the site levels? Because I think that's where the action needs to be, but I'm not always sure the sites, I'm just looking at our site managing directors, are always clear that that's happening and there's an issue somewhere further down the chain. So I think there is something there that we just need to talk with Stephen and our Freedom to Speak Up Guardians about how we get a bit more clarity and transparency without equally taking away some of the bit for those staff who've raised issues where they then feel they're having detriment because of it. It's a really difficult balance to find that, but we have to find a way because we can't continue with it taking 6, 7, 8 months to get things resolved.
No, and I mean, if Stephen were here, it's not for the want of trying on the part of Stephen and Karen and Moira. Whenever I meet with them and discuss freedom to speak up, this constant concern, anxiety, frustration, that things just take forever. And not everything, obviously, but too many of the things, and then they blow up into something often really quite serious. So we need to grasp this one. James?
Probably 2 points. So I think that on the sort of tartan rug, I think I would say we have an understanding of where the hotspots are. I think that what we could do better is to be more structured with that understanding. And to be using it to drive conversations at group exec, particularly around sort of areas where we've got sort of common fragile services, and then using that to link then into the collaboration programme. I think with some of the priorities we've chosen for clinical collaboration, we are doing it, but it's being driven by that sense of where we know intuitively that we have those challenges, and I think drawing it together in a really structured way will be helpful. I do acknowledge that the FTSU responsiveness has been a continued challenge. And it's not, some of the issues where there is a challenge with responsiveness are relatively small and transactional, and that's not acceptable. I think tone setting is increasingly important. So, I am reasonably happy now I am happy for FTSU at the SCH to escalate to me if responsiveness is just not happening. And I think that what myself and my immediate team can do is then set the tone of being very responsive, being visibly responsive, and being visibly a little bit annoyed that we've been brought in. Because if something is getting escalated to us and we're having to then step in and resolve something that really ought to have been put to bed, then I think that that then helps to set a norm, which is that things should just be resolved. That there are equally some very intractable long-term cultural issues where I think we need to set an expectation of what resolution looks like, and it's that the issues are heard and they're being addressed, but there is not a simple solution to them. So I think it's got to be the expectation management, but it can't just all be expectation management. It's also got to be a change in responsiveness and how we visibly show the priority that we give to FTSU.
I think that's helpful, James, and I think also some things just kind of run into the sand. So concerns are raised, and Karen and Moira and Stephen keep on and on and on, and it just kind of, I don't know, I'm kind of thinking of the right verb and adjective. It's not, they never really close down, they just kind of drift on, I suppose. So anyway, Jacqueline, you want to come back, and then we need to probably...
Paul does.
Oh, right, we probably need to close this one down, because it's not as though People Committee aren't all over it. But I do think it's a real issue for the board, and the fact that independently two Neds, at least one of whom is on the People Committee, raised the point.
Gillian, the People Committee can't fix it.
No. Yeah, but we can pay a lot more attention to it than we can at board. So Paul, and then Anne wants to come back. Might it be better if Anne goes first, Paul?
No, fine.
So I guess the thought going through my head when we've had this conversation is, and it was kind of prompted by Jacqueline saying, but we know where some of these places are because we've got these various sources of data, is as a board, we look at things very much by sort of, this is freedom to speak up, this is, and maybe where is the space for us as a board to think, well, what's going on in this bit of the organisation, and what are our indicators, and how do we know it's all working? And I can see you might do that at site, but where as a board do we take assurance around that?
Sorry, can I just respond to that? So I think the point here is, it's a bit like, you know, sometimes get really frustrated with my bosses in NHSE because, you know, the finance takes the finance line, the performance people take the performance line. They go, well, you must treat more patients electively, you must save more money. And the quality, you know, you get the CQC saying, you must put more staff in. And nobody ever actually talks to each other. And I think the first step of that is that as executives, because, you know, the site need to have it, the exec need to have it, and we need to find a way of collecting it all at board as well, because, and then be clear, because that's the bit then at board, because we have collective responsibility about saying, well, if Department X is the issue, we've got a plan and that's been monitored by and then we get some sort of way. But there is a bit of a rethink to think, because I think that's been the biggest, starkest thing for me, is that we do functional lines really well, but we don't bring it together. And that's what the executive is for, and I think that is the board is for. So that we just need to think about that, because it has been on my mind about how do we get that collectiveness.
I think it's been on all of our minds for some time. We've had this triangulation discussion, you know, several times, I think. So I'm really pleased, Jacqueline. It seems it's about to be landed, and you've given a clear
well, at least
date.
to go at doing it anyway.
Yeah, but there's a clear date. We like clear dates. Paul, final word?
Yeah, I mean, I completely accept what Freedom to Speak Up Guardians was saying about things taking too long and massively frustrated. It's not straightforward, and it goes back to lots of what we've talked about today. Things that, say, for example, service pressure, where we're trying to get managers released to do investigations, for example, and that's quite difficult to do. I think we've also got ourselves into a bit of a culture where we've formalised lots of things, which actually would be much better if we were bringing people together, and that goes back to some of the culture work that we've talked about. Some of our policies, going back to you know, Martin's point, well, this is an aside, but I discovered a policy which hadn't been renewed from 1999 yesterday, and it was, which isn't good. But some policies are just complicated and unnecessarily so, and that creates some barriers. So, for example, you know, we should have a panel for any disciplinary where chief nurse should attend, and that becomes really difficult. And so we've had to simplify. It's trying to make these more straightforward, more simple, some of our policies. I think there's getting stability in the ER team, for example. So we've had quite a number of vacancies. That's improving. I think things are better at ESTH, would be my observation. I think it feels as though things are better. But there's not a simple answer to this. But you're absolutely right, and it's completely right to challenge us and say, how, you know, what do we need to do to improve it? It just isn't straightforward.
Thank you, Paul. So it would be helpful, I think, Jacqueline, if in your report in September, maybe it'll be too soon because our board...
No, I think we need to do it in November when we have...
But I think it would be helpful to have a proper report back on the progress on this, so it isn't just another well-intentioned discussion that gets lost in the ether. I'm just conscious of time, so people happy to note that report. I think a really rich and useful discussion. So moving on to item 4.4, which is the George's Audit Committee report. Peter.
Thank you, Julian. I can be brief, but the primary focus of both committees, George's and ESTH, over the last few months has obviously been the annual report and accounts, and there has been a separate board discussion and sign-off on the George's side. So I'll just kick off on the George's front. I mean, following on from the board agreement, the accounts were submitted on time, clean set of accounts, so well done on the George's front to Andrew and his team. Over and above that, the other issues that we've which are touched on in the report on the George's side are the consideration of the internal audit reports. I mean, the good news there across a number of areas, they were all graded as reasonable or substantial assurance, so there's no limited or problematic reports coming through, which is a good sign. We also received the Counterfraud annual report, which again, on the George's side, was shown fully compliant. Good news. And similarly on the conflict of interest, the compliance for that we've seen on both trusts actually, an upward trajectory on sign-off. So that's, again, helpful. There's a reference to just some minor adjustments to the work programme, but they're not substantive, and I think hopefully can be agreed. So I think, Gillian, that's all I'd draw the attention to on the George's side. So shall I move straight on?
We'll take them one at a time.
Yeah, okay.
Any points on the George's paper? There's a number of actions which I'm not going to read out in total, but it's about noting the report, approving the annual report, changes to the terms of reference and the proposed work programme. People happy to support that? Yeah? Okay, right. You're back on, Peter.
Thank you. And moving swiftly on to ESDH, on the annual report and accounts, the board will be aware that we had to defer the meeting that was scheduled for last week because it hadn't quite got to the point where the audit committee and then the board could consider those. A number of factors that contributed to a delay. Some of them, we have a new auditor in place that has been, I understand from Andrew, particularly keen to do lots of sampling and other work that perhaps is just because it's their first time around. I mean, having said all of that, I think good progress has been made, and we're hoping that we should be able to move to audit committee next week, followed by a board to sign off, and again, hopefully a clean set of accounts, and that's of paramount interest. We won't be the only ones in town, I think, with that slightly late report that should have been in at the end of last week. I think there are many trusts which are in a similar position, so in that sense, we won't stand out, which is a good thing, and there'll be lessons to be learned, but nonetheless, getting to the right point, clean set of accounts is always the priority, rather than rushing it to get to that deadline. So that's, I think, all on the annual report and accounts. And although it says approve the annual report, I think we can take that when we come to the board specifically to cover the report and accounts. It's fine to agree now. I think it is in a good place.
It's the audit committee annual report, though, isn't it, that we're being asked to agree?
You're right. So in that case, stick to the recommendation. I think it's my apologies for that. But no, we'll come back to the annual report and accounts at the specific meeting next week. I think otherwise, again, the internal audit reports are in a good place. Similarly, in a moderate or substantial approval. And again, the conflicts of interest, actually, compliance rates are then at a good and improving level. So at this point, Gillian, I'll stop there. Thank you.
Thank you very much indeed, Peter. Andrew, was there anything you wanted to say about the ESTH annual accounts?
No, we continue to work with them, doing emails with them as we speak. And I think, as Peter alludes to, there's definitely pressures, I think, across a range of auditors. So the level of testing that a lot of trusts have experienced this year has been significantly higher than in previous years. And I think with this being a first-year audit and turnover in some of the team in March, some key members of the team have made the Epsom audit more challenging. So while there's definitely, I think, some issues with the auditor, I don't think, there are some issues on our side to look at as well, to be fair in terms of that as well. So.
Well, I think, we all know, don't we, Andrew, that when these things happen, it's rarely one-sided. And I know people have worked incredibly hard to land it, but as Peter so nicely put it, we need a clean set of accounts as well as the ideally we want to do both, clean set of accounts and do it before the end of June. But anyway, we won't get lost in that. We will have the meetings next week, and we'll land all of that. So the action required by the board is the same as for George's. So I'm definitely not going to read it out this time, but seek people's support for that. Yeah, lovely, thank you. And that takes us to the ESTH Estates Assurance report. Over to you, Anne.
So colleagues will probably remember that we set the Estates Assurance Committee up as a time-limited committee in February 2022. And we did that because I think the board had a number of concerns around some infections. I think we had an aspergillus something or other and various other things. You can tell I'm an accountant and not medical in any way, not even sympathetic to the ill. So we have worked our way through all the various elements that you would expect to see in place. So we've looked at water, we know all about temperature, flow and dead ends and all things like that. We've worked our way through electricity, low voltage and high voltage, decontamination, all sorts of things. And we've got to a place where we, understanding the limitations of the infrastructure that we're living with, we are satisfied that there are processes and systems in place to mitigate the risks. And, you know, and that kind of largely was what the committee was designed to do. As Andrew said earlier, we have commissioned a 6-facet survey that will give us the sort of the evidence and the database that will allow us to manage this in an ongoing way. So to that extent, our work was done, or what we initially wanted to do. And therefore we've given you a sort of closed down report which tells you what the issues we've covered and what's remaining. I did make Andrew plough through all the minutes of all the meetings to make sure that there was nothing left hanging there. So I think it's sort of time to hand this over to another committee. And actually that sort of ties in very neatly with the setting up of the infrastructure committee, because obviously when we set off, we had a date in mind for the new hospital at, in Sutton. That's moved out a bit. And then there are other issues. It's not just the managing of some of this infrastructure, but it's the managing the fabric of the buildings if they're going to have to keep going for longer than we originally anticipated. And that felt to us to be better part of an infrastructure committee than this task and finish group. So I won't go through the high voltage. I know quite a lot about decontamination now, problems with it and all the rest of it. But I won't go through all of that. And if there are any questions, then Andrew's the man. But ask you to sort of accept our kind of note and accept that we've done what we set out to do. Actually, this ought to be now covered in a different way.
Thank you, Anne. Jenny.
Thank you very much. When I was reading through this paper, I'm particularly interested in electricity because we share it on the site and I know it's a vulnerability. One reference was to high value electricity in the recommendations, and then there was a reference to high voltage electricity. And I thought it was either confusing or it's a typo, but as I read through it wasn't clear.
And it should say high voltage. I don't think there is a
Well,
high value. Well, not in my little world.
So if you leave it in 5.1, it says high value electricity.
Right. It should say voltage. But this is actually about ESTH. But you're right. I don't think we have high value. High cost probably, but not high value.
Let's not get lost in voltage and value. It should have been voltage, shouldn't it? Derek?
Yeah, I just wanted to say I've been part of the Estates Assurance Committee, not at every meeting, but I have been very impressed with the depth and rigour of the discussion and discovered, as Anne has, I think, a lot of things I knew nothing about. So I think I very much commend that. I was very assured by what was discussed at the committee and the depth of detail that we went into.
Thank you, Derek. I do think it was a good piece of work, well supported by ESTH colleagues, for whom it can't always have been easy.
And well chaired.
And I'm sure that's the case, but thank you, Derek, for saying that. So there's a set of recommendations in... Oh, I'm so sorry, Martin. Yeah, I'm so busy trying to close this down. Over to you.
No such luck.
Thanks for that.
So I'm conscious that there's been, this is excellent work that's been done in the committee. I'm conscious that there's been quite a lot of change in the estates function, and I just wanted to check if we thought there was a continuing risk, and I might get this slightly wrong, but I seem to remember when it got very hot in the summer, we had quite a major problem because the servers shut down. I don't know if that was to do with voltage or what it was. And obviously we don't need to spend long on it, but it's more for Andrew obviously than Anne. But I just wondered if that was something that is no longer a risk, and if that is on our radar, etc. Thank you.
I don't know whether you know about it, Andrew, because it's before you took over, but there was a really, really serious incident, because I remember visiting it, and all this machinery that had been brought in order to get the temperature down, and all these cables all over the place. It may be that you need to take it away and just check it out. Is that okay, Martin?
I will double check that. I mean, there was the day we hit 40 last year, there was an incident at George's with the transformer as well. We have now got automated monitoring of the transformers in the St James wing to try and make sure that that doesn't happen again. But I will look into that one, Martin. Yeah, I'll double check.
I think it's different, yeah.
Yeah.
But the team should remember.
Yeah, no, I mean, I remember it well, because as I say, I went and visited it, and the mitigations were very evident. It was visually quite impactful, really. So if you could just let Martin know, maybe drop me a copy of the note as well, Andrew, that would be helpful. So we've got the series of recommendations that are set out in 5, but rather than summarise all of those, if we could, recognising that noting and accepting the report covers all of that, are people happy to support that, knowing that we've set up our new committee, which will take over? Yeah? Lovely. Thank you very much indeed. So that moves us on to item 5, where we've got a series of items for noting, all of which have been fully discussed, I think, certainly the first 4 at Quality Committee. I'm not sure where the other one's been discussed, James. Maybe not. Maybe that does need to be discussed a bit here. But can we take 5.1 first of all? Arlene, anything you needed to add? We've already talked quite a lot about this.
No, I think we have. Yeah, I wouldn't add anything right now. Thank you.
Yeah. Okay. So what are we asked to do? Sorry, somebody's saying something. We're asked to receive the report and note it, and we've picked up the recommendations elsewhere, haven't we? Yeah. Excellent. Thank you. Next one is
PSERF.
Yes, the PSERF. We've talked a bit about that as well.
We did talk a bit about that. It's just to say that in here we have the training needs analysis, clarifying who needs what training, and I think that was an issue, particularly at Epsons and Helier, where everybody was told they had to do 2 days of training. So this makes it clearer. We talked at the committee around how we make this real, and we've talked a little bit about that now. So we will go away and work to getting something that helps it to feel more real for September.
Thank you, Arlene. Anything on this one, or can we note the update? Good. The next one is the Learning from Deaths report. Richard, anything that you need to add? Oh, he's gone. Oh, okay. Well, I'm assuming that there wasn't anything. No? No queries from anyone? I didn't see that he'd gone. I can't really see someone sitting along from me. What are we asked to do on the Learning from Deaths? Let me just get the recommendation up.
It's also for noting.
We note the continued compliance, etc., etc. People happy to do that? Thank you. Medical appraisals and revalidation. Did Richard choose this particular moment to leave the meeting? Again, I'm not particularly anxious because we've discussed them all in Quality Committee, but nevertheless, the board's asked to note a number of things. They're happy to do that. Thank you. And then that takes us to item 5.5 and the integrated care systems update, which hasn't been anywhere else.
No, it hasn't, and we normally discuss this in the the private section of the board.
Yeah.
That said,
Richard, we've just dealt with your items.
Sorry, I didn't time that very well.
No, you timed it incredibly badly. James, please keep going.
This paper is for noting. I'll take it as read. I think just draw out a couple of the key themes. There's a lot of work and challenge for the ICSs, both in South West London and in Surrey Heartlands, as we work towards the ongoing devolution of commissioning of specialist services from regional and national level increasingly to an ICS level. And we're very keen to support the ICSs to help in terms of the transformation agenda, but also the appropriate flows of patients, and very cognizant that it's a critical element of particularly the St George's element of our portfolio, and the flows from the Surrey catchment area are very important to us. We should note that we span 2 regions. We're physically located within the London region, but a lot of our flows for specialist commissioning come from South East region, and we have a little bit of dichotomy in terms of the priorities for transformation. London are prioritising new transformation in supporting appropriate identification and management of patients with early renal disease, which is becoming an epidemic, and sickle cell pathways. And this does not apply to the populations that we serve in the Surrey Heartlands area. But we're trying to walk that tightrope as much as possible. And then I think the other thing I want to flag is the emerging acute provider collaborative in Surrey Heartlands, and the intention to commence a review on children's and maternity pathways, which may have a significant influence, particularly at the Epsom end of the patch, and they're subsequently planning a review of stroke services. So I think it's very important that we maintain our engagement with Surrey Heartlands and are cognizant of any emerging themes, but that we can help shape that agenda too. There's ongoing work with South West London Acute Provider Collaborative too, which is noted in this report.
Thank you, James. I thought an incredibly useful report, packed full of information, so thank you to the team for that. Any questions to James or comments about any of it? No? So we're asked to note that report as well. Thank you. That takes us on to item 6.1, new risks and issues identified. I don't think I heard anything new. I think everything that we talked about was familiar, but somebody may have spotted something that was familiar to me but not to them. No? Okay. I haven't been told of any other business, so I'm assuming there isn't any. Which takes us on to item 6.3 and the reflections on the meeting. And I asked Phil if he would lead the reflections this meeting. So over to you, Phil.
Thank you, Gillian. So, you know, I'd like to sort of go back to the start really and talk about the visits, which I do think are a really valuable part of this this whole event really. And I agree with you, Gillian, that I think a little more time on feedback would be really useful. And I think to the point actually, you know, was made earlier about deep dives, Andrew was talking about, it would probably be good to have some understanding that there is, you know, some feedback goes back as well, and how that feedback goes back into the hospitals and how that may be. So I know that just adds more sort of effort, but there's quite a lot of good stuff goes on, and I think it is rich stuff which we could probably get a bit more out of. Certainly, you know, from my personal perspective, you learn a lot, but you meet so many people who you then gives you all the right sort of richness and colour that the hospitals are run and, you know, resourced by such caring and professional people. So I think there's something to reflect on there, which I think would be helpful. And I think, as you said, you know, that there is a lot more positive that comes out of that than negative. It was said by several of the people, and I think that's a really important thing to remember. I think then if we get into the agenda, we've had quite a rich discussion today about the challenging times we're in, whether that's industrial action, whether it's resourcing, retaining colleagues, whether it's about finances. These are really, and obviously, you know, issues, you know, all around the hospital. So there's some really challenging things, which I think I would say we've professionally talked about, and there is an acceptance that there are some challenges out there, and those challenges need to be worked on. But the other side of that, there's some very positive, I think, you know, initiatives that come out of today, like the infrastructure committee, which I think will be a place where some triangulation can take place, for instance. So back to, Jacqueline's point about triangulation, and I think there is something there where we need to think a lot harder about how we work horizontally across this business, if you want to call it business, this hospital trust, whatever, as opposed to just vertically, which I know, and this it isn't just the NHS that has that issue, that is an issue in every large business. And I think there's something we should all reflect and go away and think about how are we going to work better horizontally, which will then allow, Jacqueline to get this triangulation piece going, because and then if we do it, that culturally will work hopefully through everybody else. I think the group strategy helps with this as well. So again, another great initiative. And I'm going to carry on talking about it, James, I'm afraid. So we're going to keep on talking about it because I think there's so much good in there, which again works across the organisations. It also helps that all the trusts come together. So I think there's a real opportunity here where, gesh can come together through that strategy. I like the point that was made, I can't remember who, about it being, bottom up as well. So we're asking colleagues what they make of it, such that they can then, and we can share that across the different trusts. I think would be really helpful. So I think there's, I suppose probably the point I'd make about the trust, we talk a lot about St George's and Epsom St Helier, and I always worry that Thurza's World is, and I probably don't understand Thurza's World well enough, which is probably completely my issue, and I perhaps should spend some time to learn about it. But I do think we focus on the big buildings, the things we can see, and maybe there's a little bit more focus we could find to break into the world that Thurza is running as well. So that's just one. I think a couple more points. I think everybody who reads all these papers and can comment on them is a genius, to be honest. So I think there's a, and I wouldn't be, I'm sure I'm not the only person in the room who occasionally gets into X page of a bit and think, right, I've lost the will to live on this one, I'm going to move on to the next paper. So I think there is always, we always need to reflect that paper writing is very difficult, and any advice we can give to those writing paper to keep them succinct and helpful and of course on time would be useful. So, but overall, I think we've had a good varied discussion today. Extremely well chaired, of course, Gillian, and you nearly lost it on the time earlier, but you got it back, and then one or two of my colleagues tried to put you off course, but we of course failed in that, and Richard left the room just at the right moment with his interest. But no, I think there's a good spirit in the room. I think anyone who wants to say anything, they can say it, which is really important as well. So I would reflect that I think the two boards have come together. I think we're maturing as two boards together, which I think is the right way to go. And I think it also proves there are so many issues which are common to both. This is exactly the right way to go about it.
That's great. Thank you very much, Phil. Anybody else got any points they want to make? I wanted to react in particular to the point Phil made at the beginning, because I've been talking to Anna about how we utilise the richness that you described, the positive feedback we get from staff when we go out, but also the points they make to us that need to be picked up. And it was Jo Hunter, when she sat in on last board, that really brought it home to me, that we need to find a way of getting that fed back. So we're trying an experiment, aren't we, Anna? So hopefully it'll work, and we'll see. Certainly I will allocate more time. It felt very rushed, but the rest of the meeting didn't feel as rushed as it did last time. Last time felt very, very rushed to me. This felt, from my point of view, so thank you, colleagues, that we kind of got it right. Anyway, that's just from me. Any other points that people wanted to raise? No? What did you think? That was your first...
Oh, gosh.
Yes, I might as well get a view from the Chief Executive. This is your first joint board.
I do realise, I realised a while ago that one of the things on the job description of the Chief Exec is to be able to think on your feet and shoot from the hip sometimes. So
you've just bought yourself 30 seconds.
30 seconds. Yeah. Well done, Gillian. Doing so well. So I suppose I was pleasantly surprised that, because doing two consecutive days for those of us who did it was actually quite hard. And I was worried when we did this, which is probably what happened in the first meeting, because I wasn't here. actually today feels like we have actually managed to begin to conjoin the two, so it's a bit more seamless, and that we're not going, always going, this is only Epsom St Helier, or this is only George's, that actually we're asking each, the Neds from each one who are single hatters are asking questions of George's or Epsom and St Helier, and I think that's the right thing, because we sit here as a unitary board, not as with just one hat or another on sometimes. So I thought it was pretty good. I think we still need to give more assurance. There's some work we need to do as well about the assurance we give. But I thought we were very constrained when we didn't all pile into for noting questions, noting papers either. I thought that was good. And it does feel like a more coming together board, and I would agree, absolutely would agree with Phil about that. But definitely getting more unitary.
Lovely, thank you very much. Nobody else seems to want to say anything. Thanks to Phil and Jacqueline for that, and to Anna for responding. Well, we'll see how it works. But there's certainly, in terms of Anna's response to my challenge about getting the message back out, she was really very much on the front foot about that. We'll just have to see whether it works. Right, so I'm going to move on now to item 6.4, which it's actually a staff story today, and we are joined by Dave Woodruff. Would you like to come and sit up here, Dave? You can sit next to Jacqueline.
I'll move my lipstick, Dave.
I've done some slides, but you guys will be able to see them. It's just pretty pictures of things like that.
Oh, right. So this is a sustainability pitch, I think.
Yeah. So.
And tell people who you are, Dave, because some of us know, but not everybody.
Yes. So
and why you haven't brought Rosie with you.
Yeah.
Just press it down.
Yeah. Hi everybody, I'm Dave Woodruff. I'm a project manager at St George's. I work in James's directorate. But here I'm to talk to you today on behalf of the Bicycle User Group, and specifically around active travel, some of the stuff we've been doing in that area. So why is I'm going to tell you why active travel is important, what we have been doing, and what we need to do more of. So why is making active travel the default choice for our staff, patients, visitors to the hospital is important? I'm going to state the obvious one first. Help make people more healthy. Like, I know there's a lot of medical experience in the room, but we need to encourage our staff and our patients to live more active lifestyles and be less sedentary. We might find there's a few less people stuck on the wards if they were choosing to be more active in how they commuted about their days. So, it makes people happier. We did a transport survey recently at St George's, and we asked staff how they enjoyed their journeys, and the people who walked to work were the happiest, then it was the people who cycled, then it was the people who got in the cars, and then it was the poor people who got on public transport. So there's a lot of complex reasons around that. We asked around the time of a lot of TfL strikes, so maybe that played into it. But it's simple for me. We need to get people out of public transport and cars and onto bikes and walking if possible. And we know it's not ideal for everybody, but if there are things we can do to encourage that, let's look at them. It helps the pound in the pocket. It's getting harder at the moment. Everybody knows cost of living crisis, and you can't offer staff more and more wages, but we can help them by making kind of active travel the option that they take. My bike's a lot cheaper than some of the cars that people drive. It contributes to the green plan, to St George's environmental impact. Obviously that's a massive one at the moment, and it's huge. As an employee here, I want to see how we're kind of contributing to reduce our carbon footprint. But it's more than just the kind of the polar bears and ice caps. We need to think about the impact this hospital is having on the air quality in the immediate area. So I know in the green plan there's lots of changes we are going to make, but it's going to be really difficult to stop the smoke coming out of that stack and the smoke coming out of those generators. Whereas if I can get a few more staff out of cars and onto bikes, that's all going to kind of contribute. And if you don't care about any of that, getting people onto bikes is going to reduce the complaints about car parking. So there's that to fall back on. So they're the obvious reasons why we should be doing it. So what have we been doing? So there's been loads of changes in the last couple of years at St George, and thank you to Andrew and different teams in the hospital support. We've put on
charity.
And the charity, yeah, thank you, Jack. The kind of infrastructure for cyclists has got a lot better. We've done guided rides for new riders who are just getting on bikes. Dr. Bike, who people may recognise, he does monthly visits at site and repairs bikes for free. We put pumps outside the hospital, outside all our hospitals, George's, Queen Mary's, St John's Centre and some at Epsom and St Helier now. We recently ran a scheme where we've kind of accepted donated bikes and then Dr. Bikes repaired them, and we've given them out free to staff, so there's absolutely like kind of no cost barrier to people who want to take up cycling there. Then you see the nice picture here. On the 6th of June, we had an active travel day. Thank you, Kate, for kind of coming down for that. But yeah, so we had the Wandsworth Mayor, we had Joanna Rousell, who's a gold medalist cyclist. We had various community groups from Wandsworth Cycling Campaign, Mums for Lungs, Tooting Healthy Streets, Merton Clean Air Campaign, all kind of talking to staff what they feel works about active travel, what they feel doesn't work, and how we can get more people involved. So it was a really well supported event, and it was just wonderful to hear from staff. There's a couple of people told me they tried it for the first time, and one of our trauma surgeons, Jason Bernard, wants to do a project looking at potholes or something like that. So it's just nice to kind of hear different perspectives on active travel. But we're not there yet. Not everybody is choosing active travel where they could be. So what more do I think we need to do? Does the bicycle user group ask of the board? We need more showers, changing facilities, storage for bikes. It's great, but it's like build it and they'll come. The more people do it, the more these things get used and the more space we need. So I'm looking to the estates team when we're kind of building these new wonderful renal wings and things like that. Ground floor, yep, got it. Yeah. But yeah, let's make it the preferable choice for staff. That's the idea. We've got some hardcore cyclists that are going to do it, whether we put the facilities on or not. But now we're getting into the groups where it's like an optional. And if jumping on the bus or they're worried about where they're going to dry their clothes, then they might choose to not choose active travel. We've been asked several times to put our name to local campaigns. And this is the kind of the ones with cycle groups, the Tooting Healthy Streets. They're kind of in the ear of the council and TfL and things like that, to improve the local area for cyclists, runners, walkers, people who live here. I'm happy to put my name to those. I'd sign it on behalf of the little cycle group with a few hundred people on. But I think it'd be really powerful if St George's, if Gesh could put their name to it. Obviously, we're a massive employer in the area and really boost these campaigns. And we'd all benefit if the streets were a bit nicer. And last but not least, this is something I'm asking of you all. Give it a go. If you do drive everywhere, think about ways you could be more active in your commute. We're a really friendly group. We can point you to different e-bike schemes or guided rides or where to lock your bike up, where there are some changing facilities available. And if it's absolutely not for you, think about ways you can influence others. Lots of people in this group here, manage teams, and there may be difficulties that your team members are having where they're thinking, well, I'm going to be late that first time, or I'm not sure if my manager's going to be happy about that. So yeah, think about how you can influence your colleagues, your team members, your friends, your family, other board members to be a bit more active. It's going to make you healthier, it's going to make you happier, it's going to reduce the financial impact, it's going to help the environment, and it's going to help with car parking. They're the things I promise you, just give it a go. So that's it from me. So any questions?
Oh, I'm sure there'll be questions, Dave. I just want to thank you so much. And you actually asked to come. We didn't, which I think shows the level of enthusiasm.
I wanted to signpost to the event we were
doing. I know you did, but unfortunately the timing didn't work out. I'm sure there will be questions. Oh, I've already seen loads of hands. So I'm going to start with Andrew, Peter, Phil, and then Kate. Oh, and then Jenny. Right, I better write a list.
Thank you.
So.
I declare a conflict of interest that I am a keen cyclist, so fully support what you're doing. I'm also a cyclist who's been knocked off his bike and regularly encountered difficulties on the roads with cars, etc. So I would really support us getting behind anything we can to improve the infrastructure, so working with Wandsworth and Merton councils particularly. So I'd love to see us as a big employer doing that.
Brilliant. Thank you, Andrew. Yeah, these aren't my original teeth, so that was a different accident I had.
You're not encouraging someone like that. Peter.
Yeah, mine was very supportive, but my point was similar to Andrew's about the importance of safety. Otherwise, you're going to actually end up with more customers here than you might otherwise. And bike lanes, and I did quite a lot of inner city cycling. It's key to that, it seems to me. It really just provide a much safer environment. I just wonder to what extent that is something that you feel you're in a good place on. A lot more needs to be done, and is it a question of getting the council more on board to make further progress? And the second point was, I think it's just around the incentives or disincentives to encourage or discourage, whether it's incentive to get on a bike or disincentive to bring your car to work.
Yeah.
Is there more that you think we could or should be doing in that respect to really hammer home the message, if you like?
So with the bike lanes bit, there was a lot of good work done in around COVID. CS7 is the route that kind of runs past here, and it was fantastic when it was brand new. But we've seen recently the Tooting Healthy Streets team are really on it. It's kind of retracted a bit, and it's a bit of a push and pull between commercial developments and access. But yeah, if we can put our name behind these kind of letters that they're writing, and then I think that adds weight to their campaign.
Can I just say something about that, Gillian?
Yes.
Because I did put my name to a letter, and I had the chief exec of one of the councils phoned me telling me I'd interfered in a political issue.
Okay.
So that doesn't mean that we won't do it, but I think we just need to. And then I was all over Twitter by one of the local councillors saying, "This is terrible. This car queue is because of you, Jacqueline Totterdale." And I just left it because all the bicycle users kept emailing going, "No, it's because of the cars." So I think whilst and it's not about not doing it, it's just knowing that sometimes the politics get in the way, but they shouldn't. They really shouldn't.
I think there is a way of the board expressing its support rather than perhaps on specifics. If it's where there's a specific, I suspect, and there's a strong lobby group and the council hasn't got the money and blah-de-blah, the rest of it. But I'm sure, Dave, that the board will want to be supportive without leaving Jacqueline in that position. So what about incentives, which was Peter's other point?
Yes, so I think it depends on the individual. That's why we're trying this kind of anything goes approach. For lots of people, it is the confidence to ride a bike for the first time, so we're doing the guided rides. There's the cost element. Some people's fitness isn't there, so we've within the hospital we've got an e-bike scheme, a cycle to work scheme. There's our kind of upcycle bike scheme. So we're trying to find different ways. Yeah, but we're here as there's an inbox that staff know about for asking about ways to get into cycling and things like that. So we're trying to solve the lots of little problems rather than the one solution fits all.
Phil?
Yeah, thank you. Just to build on the incentive bit, I think there's a thing where you can do salary sacrifice for this, where you buy a bike, but you don't pay tax or national insurance, and you pay it off over 2 years or something, and Andrew probably won't like it because we probably have to, actually underwrite it or something. But oh right, good, excellent.
Cycle to work scheme.
So is that something we do?
Yeah, we've got that's our cycle to work scheme. So we've had that for a few years now, and it kind of works really well. The difficulty is, I get people asking me, could we not expand it so they can buy more and more expensive bikes? I think it is because cycling has become more popular, and things like these cargo bikes now, some of them are several £1,000s, but for me that's great. That's a car alternative. That's like somebody living, not needing a car anymore. So yes, we might ask about that later, expanding the scheme.
Is theft an issue? Sorry, I've got Kate and Jenny, but when you said about expensive bikes, I just thought, theft.
Yeah, we are a hotspot in the area, and I get asked different questions on this. So I advise people to lock their bikes in front of the emergency department, where we've got the most kind of bikes in one area. The security team are never far from there. It's got good CCTV coverage, and it's like a bit of a herd mentality. If there's so many bikes, you just kind of like a lower likelihood of yours being stolen. But unfortunately, we do have some very proficient and have been seen going in there with angle grinders and things like that. So. Yeah, the more people that cycle, I like to think that reduces the chance of my bike or anybody else's individual bike being stolen at the end of the day. Yeah.
Thank you, Dave. Kate?
Thanks, Gillian. I just want to make 2 points. One was around the safety thing, because I think that's really key and critical in how we work with councils. I have a husband who's a cyclist, and every day he comes back and tells me how many times he's nearly been knocked off his bike. Totally freaks me out. But thinking about how we do work with councils, but not get into the political maelstrom of that. And the second thing, I just want to say thank you to Dave, because I was going to say he's like an engine behind this, but that's not appropriate. I think a dynamo. And actually, he likes dogs, so he's a terrier, I suppose, is the best way. He never lets up on this, and he does it in a really nice way, and he keeps us thinking about it. And I know you do a lot of work on this, Dave.
There's
a lot of discretionary effort, I think, across the trust. So thank you for that.
Thank you, Kate. Jenny?
It's about security.
Yeah. So it has got loads better recently. The secure sheds out there are pretty much impenetrable. But one of the things I didn't mention, there's a stack of locks that we used to buy with charity money. So when we give out these upcycle bikes, I'm now giving people a bike and a lock that's pretty resilient. So we're doing our best.
Well, that's jolly good. Any other points?
I just
Thurza?
Thanks, Dave. And this is one of the risks of coming to a combined board. So I run community services in the Surrey area and the Sutton area. Had conversations with community staff about how they could start using bikes rather than cars.
Yeah.
It would be really good outside the meeting to pick your brains. When I suggested it, people laughed at me. It's like I was being serious, and I think there are a group of people that would be really, would want to actually use that. But I think it takes more planning than just saying, do it.
Yeah, our e-bike provider is really looking for those staff at the moment, because we do think it's an ideal car alternative and the battery lasts long enough and it'll probably be quicker in and out of traffic and things like that, so it should be a better day for them. So.
Call the midwife coming back.
Can you have a conversation outside, Dave? That'd be great. And Andrew,
Can I say something very quickly in support of that, which is, we've got loads of docs in the practice who do their community visits on bike, which I used to do much quicker. But we've also got paramedics who have e-bikes with all their kit on it and go out and do everything they need to do on bikes. So it's definitely feasible.
Brilliant.
right, final word. Well, Dave's going to have the final word, but you have the penultimate.
So two things. I think it really would be helpful if because I know we've begun to talk a little bit about it at Epsom St Helier, but whether we're at Epsom St Helier and our integrated care bits, we can actually support seeing if we can set something else up.
Yeah.
We haven't quite got, and see what we can do with the charity there as well, because I think all that is good stuff. It's not quite as, we have lots of access to cycle lanes. It's not quite middle of London, but it's not far, whereas we're a bit more rural in Epsom and St Helier. But I think there must be ways around some of that we can think of. That's the first one. And second, Dave also was the guiding light in our pack dogs as well. And we went from Rosie and one of her mates, who's his dog, by the way, own Twitter page, to actually, how many have we got now?
17.
17, and they are much loved around the hospitals, and actually do provide a lot of joy both for patients and staff.
I do have a day job as well.
You did make the point that you worked in James Street. We would have loved you to bring Rosie. We all love
I can't get her on my bike, I'm sorry.
So I think your big ask for us as a board is whether we can find a way of more explicitly helping with the councils, really.
Yeah.
And we'll take that away and have a
brilliant.
think about
Thank you very
because
much.
I don't
Thank
want Jacqueline being vilified again on Twitter, but I think there is a middle way where we can. And I think the councils now are in a much better place,
I think
actually,
so. I think they are.
around cycling. So I think they would welcome our support, actually.
Oh, brilliant.
So thank you very much.
Thank you very much for having me, yeah.
Well, no, it's great to have your enthusiasm. It's very infectious. It won't get me on a bike driving from Surbiton, but if I lived closer, I might. So.
Tandem?
Thank you, Dave.
Thank you.
Okay, so that brings us to the close of the meeting, and we're a few minutes ahead, which is always nice, isn't it? But I am going to start the private board at 2 o'clock, because I think people deserve a proper break. So thank you, everybody. Oh, sorry. The governors, there are no written questions, but the governors are looking like, why haven't we had our opportunity? John, that means you must have a question to ask.
Oh, right, okay. What about the other governors? Hilary? No? Sarah?
I cycled here.
Yay!
Oh!
1970, so there's no stopping you.
Well, that's great. Thank you for that. Okay, so we can have lunch now.
We just need lunch. Yes,